So yesterday, Sharad, you were in your department, huh?
Yes, sir. That was my department, sir.
A department. Oh.
I usually try to stay in the department, but we have 2 weeks of lockdown, sir.
True. So now the college is closed down?
Yes, sir. Yes, sir. So I had to come to my hometown. I just came down to my hometown.
And how are situations in Mangalore, Ashwin?
Bangalore is not too bad. The cases are increasing slowly, but not too bad here. Things are not out of control.
Okay.
Hi, Dr. Sharath, how are you doing?
Ashwin. Sharath?
Yes, sir.
Hi from Ashwin.
Yeah, Ashwin. Hi. I was just looking whether I have my presentation. Hari, I should not miss that.
No, you don't require one. Your tongue does all the job.
I can manage, sir. I can manage taking 1 hour of psychology or 2 hours of psychology and behavior management. But I have to show them something, right, sir?
And it's great.
What I am talking.
It's great listening to you. Really enjoy it. Great.
Thank you, sir.
Shall we go online? Shall we start?
Yeah, sure.
Yes, sir.
I'll just admit all the. We'll wait for another 2 more minutes. I think it's 28. So, good evening to all respected moderators of the day, Dr. Bioavailability sir and Dr. Suresh Kumar sir, APPD members, the eminent faculties of the day, Dr. Sharath Ashokan sir, who is one of the best to speak about behavior management and psychology, and Dr. Sunil Muhammad sir, who is very keen in popularizing the nitrous oxide sedation in our state, and Dr. Ashwin Rao, whom you might have heard during the ISPPD conference about his various tips how to do pharmacological behavior management in children. So we have all these three eminent faculties for today to share their knowledge and wisdom for next 3 hours. So with this, I welcome you all to this program. Hope we'll have an effective and efficient learning for next 3 hours. Over to Dr. Suprasit for introducing our moderators.
Thank you, sir. Good evening, all. Today, we got two senior members of APPD Kerala as moderators. Both are the organizers behind 38th ISPPD conference held in Kochi. Our first moderator is Professor Dr. Balgopal Varma, sir. Sir completed his BDS and MDS from Courts Manipal. He started his teaching career in Courts Manipal and Mangalore. After that, he worked as senior registrar at Royal Children's Hospital, Melbourne, Australia. Later, he moved to Radha's Dental College in Chennai and became professor. In 2004, he joined in Amrita School of Dentistry. He was later inducted as a member of Royal Australasian College of Dental Surgeons in the special field of pediatric dentistry. He has many scientific publications and contributed to 4 textbooks. He was a member of editorial board of ISPPD and IJCPD. He received Star Periodontist Award in 37th ISPPD conference held in Raipur. He is one of the founder secretary, and later president of APPD Kerala. Sir is currently the principal and head of periodontics at Amrita School of Dentistry. Thank you, sir, for accepting our invitation. Welcome to the program, sir. Our next moderator is Professor Dr. Suresh Kumar J. Sir completed his undergraduation and post-graduation from Courts Manipal. He started his academic career in PSM Dental College, Thrissur. Later in 2010, he joined in Amrita School of Dentistry. He has many scientific publications in his credit. Sir is an examiner for MDS and BDS at various universities in India. He has over 25 years of clinical experience. Currently, Suresh sir is working as professor in Amrita School of Dentistry, Kochi. Thank you, sir, for accepting our invitation, and welcome to the program, sir.
Thank you.
Over to you, Suresh sir, for introducing our first presenter, sir.
Thank you. Dear postgraduates, welcome you all to the another subject refreshing session. Actually, it is meant for PG Solido, so I'm not going for a speech or anything, but giving you a hint that today's session will be a little lengthy because 3 speakers are there, eminent speakers. The topic is behavior management, non-pharmacological and pharmacological. It's a very important topic as far as exam going PG is concerned. So I'll be straight going to the speaker. First speaker is, as you know, yesterday early he has completed his very good thing on psychology. Dr. Sharath, no need of any explanation or any introduction. You know him very well by now. Sharath is actually, how he is related to me is that he is a student of my brother-like person, Shiva Kumar, who is also my immediate junior when I was doing MBS. So I got a special liking for Sharath also because he is a student of mine. Over to the speaker, Dr. Sharath Ashokan.
Thank you, sir. I think that was one of the best introductions I always like. Always been proud to say I'm Dr. Shiva Kumar sir's student. And even yesterday I was telling it was Reena ma'am and Korat sir. Today it's going to be Balagopal sir and you. And every time I relate to all of you, it is always going to be related to be around Shiva Kumar sir. So it always looks like as if I'm presenting a seminar to all my teachers here. Maybe I feel you are all giving me the same feeling. But today I think I have one more thing ahead of me. I have 2 fantastic speakers who are going to say pharmacological behavior management is going to be another aspect of behavior management. So I have to try and prove my level best. We don't get into there, but again, that's only for the funny part of it. But thank you so much. Again, I'm trying to only say KSPPD because I'm used to saying KSPPD, but I should call it APPD, Kerala State. Thank you once again for giving me the second opportunity for this year. Okay, over to, I'll start directly with my presentation. So can I share my screen?
Sure, sir.
Okay. Yeah. I'll go ahead and start with my presentation for today. This is going to be on behavior management. We would rather call it behavior guidance. We don't want to use the word behavior management because it looks a little derogatory. We don't want to manage children. We want to guide children in pediatric dental practice. So the first important question which could probably be asked is this periodontic treatment triangle. We are trying to revise the third edition of Dr. M.S. Puttu and Shivakumar. And yesterday I got it, the first draft from Elsevier, and they were asking, why do you want to write it pediatric dentistry treatment triangle? Why is it not periodontic treatment triangle anymore? So it's not that it's periodontic treatment triangle or pediatric dentistry treatment triangle. Wright is the pioneer who has worked in behavior management. In 1975, he published his first book, the first edition of G.Z. Wright on behavior management, and then he had termed it as periodontic treatment triangle. And now we don't use the word periodontics predominantly. We are trying to shift to pediatric dentistry. And in 2014, G.Z. Wright, along with Ari Kupiecki, has published his second edition. Almost about 25 plus 14 is 39 years, almost 40 years later, he's published his second edition book. And we have lots of modification of this periodontic treatment triangle. But I think what you need to remember, I remember setting a question paper for KUHAS or for MGR University. I've always asked this question: what is Wright's contribution to behavior management? Right? It could be a full-fledged essay if you want. If it's going to be Wright's contribution, I think you must write the definition of behavior management. You must write about this periodontic treatment triangle. Periodontic treatment triangle. What kind of a treatment triangle is this? Can I see something on this chat box? What kind of a triangle is it? Mathematics. What kind of a triangle is it? The triangle is equal on all sides. So what kind of a triangle? Don't tell me I didn't want to learn maths, but it's still all right. Yeah, I got some answer. It's an equilateral triangle. Fine, fantastic. Thank you. An equilateral triangle means it's equal on all sides. We are equidistant from each other. Three important people equally distantly placed. That means everybody has a role to play when the child has to be treated, right? So the child is the focus of attention. That's why he's placed at the apex of the triangle. The responsibility is shouldered by the seniors, the adults, which used to be family or the mother in 1975. Now it's the parent or the caregiver. And now it was only dentist. Now it has become the dentist, the dental team, and his environment. That means your dental practice, the place, the setup, your assistant, your receptionist, everybody comes here. Society was added in between, in center, and now we are trying to put it around society. Why do we place society around? Because it influences the child, it influences the dentist, it influences the parent. The society does not influence only one. Right? Initially, society was placed in the center. Now you can see society is placed around everybody. That means everybody is influenced by the society. So if there is a question, you must always write about this triangle. What kind of a triangle? Who's placed at the apex? What forms the base? Why is there a double-sided arrow mark? Can somebody type there? Why is there a double-sided arrow mark there? A double-sided arrow mark indicates something. There's something which is constantly changing. If there is something which is fixed in one question, we call something in physics. If there is something which is changing, ever changing and rolling, then what would we call? Something about physics? No, not reciprocal. Anything else? Something which is fixed? Yeah, very good. Static and dynamic. It's a dynamic relationship. Fantastic. A dynamic relationship means an ever-changing relationship. A child who walks into a dental practice for the first day, very happy, need not necessarily be happy on the second visit. A child who is crying today might be happy on the second visit. A child who is happy on the first visit can be very sad on the last visit. It can happen because you always need to remember that every child who walks into the dental practice, you always treat him like as if he's walked in for the first time. Every visit should be treated as if he's walking in for the first time. Please remember that. Okay. So there was one question yesterday. How do you treat children with temper tantrums? How do you treat children with apprehension? A fearful child, a timid child, a shy child. I'm only going to give you a broad outline. I told you yesterday, there's no universal formula to it. That means everybody has, there's no universal formula like apply this formula, it will work. There's nothing like that. right? If I tell you that I have mastered child psychology, if somebody tells I'm one of the good speakers, I can take it, but I should probably take it to my heart and feel happy. I can't take it to my brain because every now and then there's one child who walks in and says, Sharath Ashokan, your principles are thrown out of the door. Your principles are put into the dustbin. Because you don't have a universal formula in treating children. You need to experiment every time. You need to work on different things, right? So only please remember, if there is a question asked, you always look at the formula. The formula is only one thing for a question paper. A question paper, when you have a child walks into the dental office, so you need to know certain things. You need to assess the behavior of the child. You need to look at what could influence the child's behavior. Then you need to know whether the child would be cooperative or not cooperative, right? The child is either going to be positive or negative. If the child is positive, you don't need behavior management or behavior modification techniques. But if the child is fearful, if the child is throwing temper tantrums, if the child is apprehensive, that means the child is not cooperative, the child is not being positive, then you try to apply some principles of psychology, try to apply some modifications and change the behavior. And that's how your formula should be. The answer written for any question which is related to fearful child, temper tantrums, will always have the same set of answers. But the point is, you have to assess the behavior of the child. And that's how my whole presentation today is going to go. I just showed this particular slide only because this is a short notes I want you to remember. I want you to write 1975, write an Ari Kupetsky, 2014, the second edition, and Society Comes Outside. What is the ratio of treating children? It's one more thing which you need to write. If I have to treat one of you here, if I have to treat Rizana or Sweta or somebody, then I ask you, I explain it to you, and then I treat it. If I have to treat a small child, then how many people do I communicate with? How many people should I be talking to? 1:2, fantastic. So that means I have to talk and convince 2 people, and each person's cognition is entirely different. So for a child, I might have to talk differently. For the parent, I might have to talk differently. And that's where we are heading to. Okay. So what happens is, you need to understand every time a child comes in, if a child is throwing temper tantrums, you see between 0 to 15 months. If the child is very apprehensive, you see between 15 months to 2 years. If the child is apprehensive or very timid, he's very shy, you see between 2 to 6 years. So basically, the first thing you have to ask is, if the question is very broad, saying child throwing temper tantrums, that means it's a very broad question. That means you have everything on earth to write. But you have to try and say, if the child is belonging to 0 to 15 months, throwing temper tantrums might be because of fear of anxiety, fear of separation from the parent, fear of stranger, we could be something. So you need to know what age group the child falls. As long as the age group is not mentioned, that means whether you can establish communication with that person or not. If the child is throwing temper tantrums at 7 years, at every 8 years, definitely you can establish communication. So communication would be the key in establishing in treating any child, whether he's apprehensive, shy, or throwing temper tantrums. But how do we do it is the question. And that's what we're going to see here. Okay. So first thing I want you to do is, when a child walks in, should be the assessment which the dentist does. The assessment is not the behavior rating scales. Please take this. The assessment does not begin with behavior rating scale. The assessment begins with in which age group the child falls. Because yesterday we've been talking about different psychology. So the minute the child comes in at, say for example, let me tell you, preschooler. Let us look at preschoolers, 2 to 6 years. Can I ask you, what is the most characteristic feature for a preschooler? I want some answers in the chat box. If a preschooler, imagine a child who's going to pre-KG, UKG, LKG, okay? We call them preschoolers, but in our Indian country, we always send these children at 3 years, 4 years to school. But still, preschooler, what is the most characteristic feature? Okay, stranger anxiety, I'll take it, but stranger anxiety, something else. What is very characteristic of this thing? Curiosity, yes. Separation anxiety, imaginative, yes. Something else. I'll give you an example. The child goes to the school. The child looks at his teacher, right? Then he comes back home. He tries to act like the teacher. The child comes to the dental office. He tries to act like the dentist. He tries to do something fantastic, imitation. What is the most one thing? Role playing is the most characteristic feature of a preschooler. If role playing should work, okay, if role playing should work, what is the best behavior management? You have used the word imitation. So if role playing can work and you have used the word imitation, which is the best behavior management technique you can use for a preschooler? Fantastic. Modeling. Modeling works on dash principle. Modeling works on dash principle. Which theory? Modeling works on which theory? Which theory does modeling work on? Which learning theory? Not classical conditioning. Yes, social learning theory. Yes, social learning theory. Social learning theory. Other names of social learning theory, and who put forward social learning theory? Who put forward social learning theory? Not Erickson. Yes, Albert Bandura, right? So that's the correlation. See, every time you get a question, you try to say if the child is actually a preschooler, the preschooler has a characteristic feature like role play. An infant or a toddler, 0 to 2 years, separation anxiety, trust versus mistrust. The child is not going to trust you. You are a stranger. So the child has a separation anxiety. He has a fear of stranger between 2 years of age, right? So you must look at in what category the child falls in a Stone and Church classification. If a question is asked, you will put it like as if the child belongs to this particular age group, I will probably do this. So that's the best way to go about doing this, right? I want to give you one more point. Please remember this particular slide. Any question which is asked related to this, less than 3 years of age, fear of falling, fear of sudden noise. That's exactly why we don't want to use a handpiece or move the chair suddenly, move the backrest suddenly, put a light in front of the eyes of the child. Don't do that. Your teachers keep telling you don't move the chair. If you're going to move the chair, you put your hand on the chest of the shoulder or the chest or the shoulder of the child so that you support him and then move the chair, right? Move the backrest. Because the child has a sudden fear of falling, right? Fear of noise, sudden movements, fear of strangers, separation of parents. So these could be the core problems for a child to be scared, right? 4 years, fear of bodily injury. What could be the most common, 2 common reasons of bodily injury here? In dentistry, 2 common reasons for bodily injury. What could be the common reasons? LA, fantastic. Anything else? Whatever it is, you do something else and that could be more scary. Yes, aorta drilling. So the drill and the injection could be something very scary for the child, right? Okay, 5 to 6 years. The most important, proud of their possessions. So if you try to talk to 5-year-old children, okay, they like fantasy, imaginary play. You can talk about superpowers. You can talk about Superman, Batman, Chota Beam and all these. You can talk about possession. So to what age group, how do you communicate becomes important. What could be the possible or probable fears associated with that particular age group? Then you try to counteract and then you can write your answer in such a way. 7-year-olds, right? Can somebody tell me 7-year-olds? Here it says logical reasoning. Can somebody remember in which category under cognitive theory will the child come under? 7-year-old, something we spoke about yesterday, maybe not very old. It's only yesterday we spoke about a 7-year-old. I said it is like rule book. Somebody says concrete operation, one says formal operations. I told you yesterday, 7-year-olds are to the 2nd standard to 3rd standard, 4th standard kids. Not pre-operational, definitely. Concrete operations, it's a very, the rule book, it is very sacred, right? Logical reasoning start coming a little later at the formal operation stages, but you understand reversibility, conservation, right? So you can give them some logical reasonings. Okay, one important thing which I want the postgraduates to understand is when you join first year, you might have thought that behavior management of children above 5 years and 6 years you can manage. 3 to 5 years you are pretty scared, so you want to push it to the other post copies, right? It's not because at 5 years and 6 years you have actually learned to manage children. Actually, 6 years and 7-year-old children manage by themselves. It's very easy for us to do. We just have to talk to them. You have to talk about possessions. You have to talk about some game. You ask a 7-year-old child, can you hold the suction? Right? He thinks, poor guy, this guy probably cannot hold the suction. He likes competition, right? He likes competition. So he wants, if you look at the word, the mode in Erickson, the word in yesterday I gave you the mode in Erickson and Sigmund Freud. If you look at the word mode, it says competence, right? So 7-year-olds want to compete. They are susceptible to praise. Schools, they always give them certificates, they give them a sticker. So anything which is a praise, a word of praise or something, a reward could always work for 7-year-olds. So if a child at 7 years is throwing temper tantrums, that means all you need to, because they're alternatively brave and coward, right? So they're actually brave, they want to be brave, but they're a little coward. So you have to resolve the fear. That means you have to communicate there. But a 5 to 6-year-old, it's very emotionally unstable. So you have to talk about some imaginative stuff, right? So remember that which age group the child falls. Remember in which part of psychology theories they come under. and then remember this slide, and then you can have your formulate your answers. So there's no universal formula. If they ask you temper tantrums, you can't write an answer. Temper tantrum for a 3-year-old is different. Temper tantrum for a 5 to 6 year is different. Temper tantrum for a 7-year-old is different. Luckily, the question paper will always ask apprehensive child. The question paper will say throwing temper tantrums. So it's easy for you. You have to remember a few slides and then try to answer accordingly, right? Okay. The next slide. Frankel. 2 important classifications which I want all postgraduates to remember will be Frankel, and the second would be Wright. You can have Wilson's classification, Lamshire's classification, lots of new classifications coming up. Please remember, all classifications will have its own merits and demerits. You are a science student, right? If you look at Zsigmondy-Palmer system, then universal system, then your FDI system, every system had its own merit. Evolution of any system or evolution of a classification always has its own merits and demerits. There's no one particular classification which is the best, right? It's just not possible. So you have to remember 2 things for practical reasons and for theoretical reasons. What do you want to know? Whether you need to behavior manage this child, whether you need to modify the child's behavior. How do you decide whether you need to modify the child's behavior? Whether the child is going to be positive or negative. So this most simple classification would be Frankel's classification. So remember, type 1 starts with definitely negative and type 4 ends with definitely positive. Please make sure you know the difference between definitely negative and negative. Negative is just reluctant. Definitely negative is refusing treatment. So please remember, extreme negative behavior, throwing temper tantrums, again comes under definitely negative. So a definitely negative child obviously needs some behavior modification to make sure he comes into positive. That's more than enough. A change in behavior is always possible in a pediatric dental practice. So a child comes in negative, he can go happy. A child comes in negative, he can stay negative. So there is something which Wright modified later, which he called it as a right-sided arrow mark, which indicated the change in behavior. Please remember, Wright modified this Frankel's behavior rating scale. Frankel only called it definitely negative, negative, positive, and definitely positive. Wright was the guy who said double minus, minus, plus, double plus. So Wright was the one who gave the symbols, and he also gave another symbol, which is the right-sided arrow mark, which indicates the change in behavior. Wright's classification is one of the best classifications because Wright says no child is uncooperative. Okay, you have to be a little careful here. Some of the old initial edition textbooks of some reputed books in our own country have the word uncooperative in Wright's classification. Please remember, Wright's classification does not include uncooperative behavior. According to Wright, every child is very, very cooperative, right? Whether the child is cooperative or lacking cooperative. So I want some answers here. Who is lacking cooperative? Somebody who is not cognitively good enough to understand what we are trying to tell him. Okay, there are studies by Festa, Rudd, all in 1993s, 1973s, and all of them kind of gave the same answer, saying that a child needs about 30 months of cognition to understand whatever the dentist would talk about. How to accept dental treatment, the child needs a minimum cognition of about 30 months. So can I have some answers here? Lacking cooperative ability. So who could be children? Okay, Sweta, 3 years. 3 years is 36 months. So yes, SHCN, children with special healthcare needs, and children between 2.5 years to 3 years. 2-year-olds are called terrible twos, troublesome twos. They are very, very prone to throw temper tantrums. Lovely off the dental chair. But the minute you sit on the dental chair, that means they won't listen, right? So these are children who lack cooperative behavior. They're not uncooperative. They lack the cooperative behavior. Potentially cooperative is like the postgraduates here. All the postgraduates here, I would call you potentially cooperative. That means if you really want to learn, you can learn. If you don't really want to learn, you don't have to learn, right? So you are capable of being cooperative with the faculty members, but you're potentially cooperative. Uncontrolled, right? Uncontrolled. You are in a state of war, right? Whatever the HOD tells, whatever the teacher says, you just not bother, right? Uncontrolled. Uncontrolled would equate to temper tantrums. Rolling uncontrolledly, it's uncontrolled. Just remember UDTTW. That's how I used to remember when I was a postgraduate. Then it becomes very easy. The child who really rolls on the floor, uncontrolled behavior, then it's a defiant behavior. That's stubborn kind of behavior. Whatever you say, I'm not going to listen to you. So this is defiant behavior. You're going to write one word, defiant, equal to stubborn. Uncontrolled temper tantrums. Timid, shy. Tense cooperative, the cat on the wall behavior. The tense cooperative children could be the real cat on the wall behaviors, right? Because they could actually become cooperative, but they're really tense. They're really the scared guys, right? So if you really help them, they can become cooperative. If you really don't allow them, then they probably become defiant or uncontrolled. So they are very, very, you're supposed to be very careful with these guys, the tense cooperative guys. They're actually tensed. They're scared. They're apprehensive. Whining is, right? That sound, whining kind of sound which keeps coming, right? Not a very good kind of, not a real kind of an uncooperative behavior. A potentially cooperative will allow you to do the dental treatment, but keeps making that sound. What kind of a cry? Elsbach 1963 has classified 4 different types of cry. So if I tell you whining, what kind of a cry will you relate it to whining? Elsbach's cry, 4 different types of cry. Anybody? Okay. When I come to Elsbach's cry, I want you to remind me, not obstinate. I would use the word obstinate with defiant. Okay. Defiant, stubborn, and obstinate would be the right word. Defiant, obstinate, and defiant. Stubborn. Okay. Now what Wright did was, after 30 years, this guy comes back with Harry Kupiecki and adds one more now. So if you are a postgraduate student, you must write in Wright's classification, passive resistance. Passive resistance is added by Wright now. Stoic is not added here. Stoic is another big mistake in our Indian textbooks. Stoic does, probably it fits in here, but it cannot become Wright's classification. Wright did not give the word stoic. Stoic is seen in dash kind of children. I want to hear this. I want to see some answers. Stoic behavior is seen with abused children with child abuse and neglect. They probably have that stoic behavior because they've had so much of more trouble, right? They've had big trouble in life. They've been beaten up so many times. This dental treatment, LA and this drill doesn't really affect them. So they have that plastic kind of face. They're not really scared, right? Passive resistance is commonly seen in adolescents. They really don't allow you to penetrate or look at your eyes. They don't allow you to look at their eyes. If you try to establish an eye contact with a child, it's very easy. But if you try to penetrate the eyes of an adolescent, it's just not possible. They'll just say, do your business. I'm okay. If you tell them to open the mouth, they'll open it. You tell them open a little bit. They just passively resist. They're not actively resisting. They're not really interested. If you try, when you're talking to an adolescent, okay, when you're talking to, I keep telling this, when you're talking to a small child, you can always ask who got this t-shirt for you, who got this clip for you, who got this bindi for you, okay, who put this nail polish for you, right? But you can't go and ask an adult patient, who's your best friend, what did you have, who bought this shirt? Exactly the same thing. You cannot go and talk to an adolescent like this. The adolescent does not want to come and tell you, did you study in the same school? Oh, you studied in Sacred Heart. I also studied in Sacred Heart. It's not working with adolescent. Adolescent children do not like to be related to them, right? They have their own team crowd because this adolescent phase has one characteristic behavior according to Erik Erikson. Can somebody tell me something? Erikson says most characteristic feature of adolescents. Who are they? What is it? Like preschoolers, I said role playing. Adolescents, what do you think is the most important feature? No egocentrism. No egocentrism is present at birth. That egocentrism is fine. That is adolescent egocentrism, which is personal fable and invincibility fable. That's fine. But I'm asking you something else. What are they? Who can influence the adolescents the most? Peer pressure, very good. Peer influence. The peer influence is the most important thing. They are not bothered about other people. They're bothered about the peers. So if they have a group of people, you as a dentist cannot become their peer. So you cannot try and communicate or converse with somebody who does not want to be related with, right? So they can't place you in the same boat with them. So it's just not going to be. So this is kind of behavior where Wright thinks that this is also a potentially cooperative behavior, but they're not resisting. This is called passive resistance. Okay, so let me go ahead. Fear, anxiety, phobia could be another important thing to see. Okay, which comes first? I want to know which comes first. Fear or anxiety, which comes first? Anxiety. Okay, fine, great. Now I'm happy because I'm going to teach you guys at least something new. All the toppers, like whoever been answering, everybody says anxiety. So now we put it into dustbin and we take fear first, right? We got to take fear first. Okay, you're waiting for your result. Okay, you're waiting for your result. Okay, imagine it's been published on the internet or it's put up on a notice board. You're going and looking at the result. Is it fear or anxiety? When you're waiting for your result, when you go and look at the notice board, is it fear or anxiety? Okay, Rosanna says anxiety, so everybody's going to write anxiety, anxiety. Somebody says fear now. Okay, I'll give you another easy clue to remember this. You're waiting in the exam hall. The question paper is coming in, right? Everybody is waiting anxiously for the first person. The first person who gets the paper has a triumphant smile, looks, turns back and says like that, right? When you're waiting for that expression from your friend who's sitting and receiving the paper, is it anxiety or fear? Is it anxiety or fear now? When the question paper comes in an examination hall, is it fear or anxiety? Now Rosanna says fear. I'm waiting for the other people. When the question paper comes to you, is it anxiety or fear? Okay, people are not answering. I don't know which boat to take you in, right? You're all the cat on the wall people, right? Okay, fine. You have to make some choice. Okay, when you're waiting in the examination hall, you're anxious. This is not fear, right? Fear is to a known danger. When you go and look at your result, there is a pass or there is a fail. There's something happening in your life. It's going to be a pass or a fail. You propose to somebody and wait, it's going to be a pass or a fail, right? The fear is there, right? The exam result is fear. Whatever situations which lead to the fear can cause you anxiety. You don't know which could cause you anxiety. That's why it's called unknown danger. Anything which could be related to that. If you don't get a good question paper, that leads to fear because the fear is going to tell you you're going to fail, right? So the fear has to get established first. A child who is looking at a snake does not know that this will bite. So he goes and touches it. A child who is looking at a candle does not know it's going to hurt him. He touches the flame. But the minute you tell them that there is an ant hole and the ant hole can have a snake and a snake can bite, every ant hole is causing us some anxiety because it relates to the fear. So anxiety and fear are always interchangeably used. We use the word DFA, dental fear and anxiety. Please remember, fear has to get established first. You must know what is the danger or threat. Then anything which could lead to that is your anxiety. So fear establishes first. Anything which is objective, that is the person has had a direct experience, that it becomes objective fear. Anything which somebody told them, right? Anything which somebody suggested to them is a subjective fear. The child told his friends that I'm going to have a dental treatment. The friend says, oh, you're going to dentist. Go. The dentist will have an injection. They will have a drill. It's going to hurt you. And all that. That is suggestive fear. It's a subjective fear. The person who's coming to the dental office has not had any direct contact. None of his sense organs has been associated with dentistry. If it is associated with dentistry objectively, then it becomes subjective fear. Otherwise, it's a suggestive fear or a subjective fear. A mother who's holding a child of the dentist. Sorry, I don't think the mother can hold the child of the dentist. The mother is holding the child of the hands of the child. Thinks when the dentist is bringing the injection close to the dentist, is bringing the injection close to the child's mouth. The mother thinks that he's going to give more comfort. The mother tries to squeeze the child's hand. The minute she tries to squeeze the child's hand, she is going to pass on some information saying that be careful, there's something more dangerous happening, right? So this is an imitative fear. Something which is passed on could be another kind of a fear, right? Okay, sorry. I think I interchanged that. Suggestive, they're suggesting something. Imitative is somebody, we are trying to learn it from somebody, right? Somebody comes and tell you that I had dental fear and I had some pain, then we are going to imitate them, that it's imitative fear. Suggestive fear is when the mother squeezes the hands and then the child thinks that something more dangerous is going to happen. So subjective fear actually did not happen. Objective fear actually happened. So please remember this basic difference. There's one wonderful article which all of you must read, Chapman and Kirby Turner, right? British Dental Journal, 1999. 5 reasons for dental fear. All of us must accept that there is some related unknown reasons for fear. There is always some related pain. We cannot say I'm a painless dentist. Lack of trust Nobody trusts you. There's always, you're a stranger. The child who comes in does not really have to trust you. Loss of control, right? Loss of control. Even powerful people, politicians, policemen don't like dentists because they have to come and keep their mouth open like that, but they can't speak. They don't have a word here, right? That means who's in control? The dentist is in control. So dentistry always has something called loss of control. And there's one more thing called fear of intrusion. Intrusion into a personal body cavity, right? A prick into an eye, a prick into a ear, a prick into a nose, and a prick into the mouth is the same for a child. But we as dentists from third year, we are so used to pricking into the mouth. So for us, LA is very easy, but it's a personal body cavity. So intrusion into a personal body cavity is fear of intrusion. So the 5 reasons why the child has a right, the child has an inborn right, I will say, that he can fear about dentistry. So it's your responsibility to nullify all these things and make sure the child understands and guide him through the dental fear, right? That means he has to have the dental fear because it's possibly present because of these reasons. If it's not there, it's good. But if he has that, it's fine. But you just have to take care of it, right? Okay. So this is another good article which I want you to see. Klinberg, 1995. Lovely landmark articles. Behavior management problems. When I was a postgraduate student, I never used to understand BMP, behavior management problems at DFA. I thought it was always interchangeable. Any child who's coming and rolling on the floor, I thought it always had dental fear and anxiety. Anybody who has dental fear and anxiety will come and show uncontrolled movements. But actually, it's not like that. A person who has dental fear and anxiety might show more behavior management problems. Behavior management problems is bodily movements, lashing out the hands, throwing up the body, right? Giving a push, trying to shrug the shoulders, trying to move away. Anything to do with the body and then trying to move away and doing some activities, behavior management problems. Really difficult to manage the child. But this could be related to dental fear and anxiety. But imagine there is a 10-year-old child and there is a pre-shedding mobility. If you do just like that, you do that on the tooth, it's going to fall off, right? But what happens is the child actually will not allow you to do that. He does not have real dental fear and anxiety, but because he's a 9-year and 10-year-old, he can actually resist. He might not allow you to put your forceps there. So not all children who exhibit behavior management problems have dental fear and anxiety. So this is the landmark article which says how are dental fear and anxiety DFA related to BMP, and I want all of you to definitely have a look at this particular article. Okay, cry. I told you about this cry. So somebody said obstinate, right? The word obstinate, I told you to relate it to some word. I didn't use the word obstinate specifically there for a reason, because I thought I will ask you that. Obstinate is equal to what? Can I have some answers? Defiant. Defiant equal to what? C. Stubborn. Very good. Defiant, stubborn, obstinate. All these words. You are in a state of war. There's one more word which is being used in the textbook. Anybody? Starts with B. A state of war cry. If you see 300 Spartans or any movie which has a war, right? Then the Talabadi comes and touches with the sword. They make a loud cry before they march forward. What kind of a cry is it called? Anybody knows some good English words? A state of war cry is called a belligerent cry, right? I'm just typing it for you. Belligerent cry, right? A belligerent cry. A belligerent cry is a state of war cry. A defiant state of war cry, an obstinate cry, a defiant cry. A frightened cry. What's a frightened cry? A child is lost in a fun fair. Lots of people around, right? Suddenly he feels very scared, right? He's very scared. Yes, very scared. So how do you think he's going to cry? Is he going to cry? Yes, with an aorta. Okay, he's going to cry. Is he going to cry a torrent of tears, or is he going to have one drop of tear from the corner of his eye? A child lost in a fun fair or a crowded place, is he going to cry a torrent of tears or a single drop of tear? Somebody who's scared, how do you cry? A torrent of tears. Very good. Frightened cry. So usually, I tell my postgraduates, still I find out what cry it is. I don't get up from the chair. I wait to find out from my chair what kind of a cry is it. If it's an obstinate cry, I try to listen to what my PG is doing. I want to know what behavior management they're doing. If it's a frightened cry, that means you need to communicate. If it's a hurt cry, the child knows that you are all treating them like guinea pigs. He's sacrificing his tooth for you. You think you are in enamel, but you are into dentin. You think you are into dentin, but you're already into the pulp, right? You are doing indirect pulp capping and you already entered the pulp. The child is trying to compensate everything and he's trying to help you. But suddenly he's hurt. He really has pain. Is he going to have a torrent of tears, or he's going to have one drop of tear from the corner of the eye? One drop, yes. A hurt cry, when you have a jab, when you have a prick, when you had your COVID vaccination, if at all you were very, very, really hurt, right? You have one drop of tear coming there. That's a hurt cry, right? So you can actually hear the cry of children. Is it a frightened cry? Is it a hurt cry? Is it an obstinate cry? Is the child not even listening to me? Is he being belligerent? Is he being in a state of war with me? Is he defiant? Is he obstinate? Is he stubborn? Okay. Compensatory cry. What kind of behavior could it be related to? Somewhere in Wright's classification, I told you, there's some kind of a cry which says, yes. The child stops the sound the minute the aorta comes up. The aorta is taken off, right? The child starts doing this. But when doing it, he has that small sound coming along with the aorta sound, right? So that kind of a cry is called a compensatory cry. A compensatory cry is not a true cry, and I want you to remember this. So any question, any short note asked about frightened children, you can talk about frightened cry. If you talk about frightened cry, you can write something related to the fear of children. You can justify reasons for dental fear. The fear could be because of 5 reasons. So any essay asked in behavior management, 75 marks question or a big essay question, that's like cakewalk. You must be writing everything in the world, whichever you know, if you know the coherence or the order in which you must do. Okay. Now I've seen the child who walks into the dental office. Okay. So see, I'm actually telling it like a story for the essay questions only, right? Whatever, it can be used in private practice also. So it could be used in both ways. So I'm not putting it like as if I'm just trying to narrate it like a story. But when you write the essay or a short notes, you put it in this format. The other person who could be very, very important there is the presence of the parent. The presence of the parent or the absence of the parent, right? So the parent could be giving complete freedom to the child or might have complete control over the child. The parent might love the child so much or might be treating the child like very hostile person. They really don't want, they could be neglecting the child, rejecting the child, right? With child abuse, neglect, anything. So there could be 4 extremes. It could be autonomy or control, love or hostility, right? A parent who's scared of dentistry and who's a very loving parent, unfortunately, they pass on the information to the child. And that's what Bell called it as one tail. A parent who is actually scared of dentistry might unknowingly transfer his fear to the child, right? So you have to be very careful in having the child inside the dental practice. It's very, very good in private practice because I wouldn't want my son to be treated by a dentist and I'm waiting outside. As a postgraduate student, it always helps you learn, okay? The quality of treatment is always going to be better when you have the parent inside, right? So in my department, I always tell the postgraduates to have the parent definitely sitting right next to them, just to make sure that they are also feeling comfortable, the child also feels comfortable. But the role of the parent has to be very, very clearly defined. They must not intervene in between. They must not talk unnecessarily, when to talk, because they can always give this kind of fear which can be passed on. Right. Okay. Parenting styles. Okay. Baumrind in 1973 suggested there are 3 different types of thing: authoritative, authoritarian, permissive. Right. McCoby and Martin added one more, which is uninvolved or neglectful. Okay. Which kind of parenting style is the best? What do you think? Obviously, any parent for that matter will be a combination. You can't have a parent who's going to be one at a time. But which kind of, does anybody know what this parenting style is? Okay, authoritative. Okay. Look at this. Communication flows both ways. Always, always communication should be both ways, right? The parent expects a lot from the child, but is also supporting, right? Okay. If I tell you authoritative, which movie is that? I don't remember any big movie I can tell you. Okay. 3 Idiots. What kind of a father is Virus? Dangal. What kind of a father is Amir Khan there? Has anybody seen this? Movies, yes. Authoritarian. It's very demanding, but not supportive, right? Whatever has to be told has to be done. That's an authoritarian parent, right? I know a lot of Tamil movies. I don't know any Malayalam movies, but anyway, think about some movies to relate to authoritative parents. Authoritative parents are supporting and demanding. Authoritarian parents are demanding, but not supportive. Permissive parents given, right? I'm sure if some of you are Harry Potter fans, can you give me an example of a permissive parent there? A permissive parent in Harry Potter series. There are, yes, not Dursleys, it's Dudleys. The Dudleys actually, even Malfoys, right? Most of the time they are very undemanding, but very supportive. The Malfoys, the Dudleys, right? I can't think of more examples because it's all just coming like that. So you can think about different parenting styles. You can look at the movies and look about what kind of a parent you should be, what kind of a parent could probably be, looking at the behavior of the child, right? The behavior of the child could be assessed by the parent, and the parent is also contributing there, right? So the presence or absence of the parent also plays a major role here, and you should be able to look at the parenting styles. Okay, now I'm going to quickly rush through. I have probably about another 15 to 20 minutes. I think I have 20 plus minutes. So behavior management definition, you will write keywords. Whatever is in red are the keywords. Effective treatment, efficient treatment, right? What Anandaraj was telling today also, effective learning, efficient learning, right? And here you must always remember effective learning, efficient learning, and instilling a positive attitude, right? Behavior guidance is totally different. It means the same, but we are looking at building trust, removing fear and anxiety, establishing communication and education. So these are the words, but remember, it's an individualized interaction. For each child, it's different. Whatever asked for one person need not be necessarily applicable for the next child. So it is an individualized interaction between the dentist, the patient, obviously the family also. There's some effective communication, some amount of education. Ultimately, there must be a trust which is built, and the dental fear and anxiety must be thrown away. That's what it says. Behavior modification. Okay. One thing I want you to understand, any question asked, behavior management is the broadest heading. Under behavior management, you have behavior modification. You assessed the behavior of the child. You understood that the child who is walking into your dental office has the right to have a dental fear, right? You looked at the periodontic treatment triangle. You want to look at the parent. You know what could be the parenting styles. You have seen a little bit about the parent. You have seen how the child could probably behave. You have seen the age of the child. You have looked at what theory of psychology that particular age group would characteristically be giving him some basic behavior. Then you see whether the child is falling into Frankel, which category, Wright's, which category. Now you've decided he's under positive. No behavior modification. Go ahead and treat him well. Make sure he is positively reinforced. If in case you see that the child is negative or definitely negative, now you need to apply some behavior modification. So behavior modification is below the broad heading of behavior management. That's behavior modification. So behavior modification comes in when you want to modify somebody's behavior. But you can't behavior modify somebody just like that. There has to be some rules. It's an attempt to alter the human behavior in a good way or a bad way. Obviously, you want to do it in a good way, right? In a beneficial way, in accordance to some rules. There has to be some rules for changing somebody's behavior. You can't just hypnotize somebody and then change their behavior. An emotion or a behavior should be altered in a beneficial way. But it has to follow some rules with this loss of learning. That's all the definition says. Behavior shaping. Behavior shaping is still a smaller category. Under behavior modification, we have behavior shaping, right? So behavior shaping, you keep doing something, right? The first time you came into your department, okay, 3 years back, you did a tooth carving. By mistake, you did a fantastic carving, right? And you show it to your teacher. The teacher says it's fantastic. You're surprised. You thought you never knew how to do carving. Then the second time you went, he called everybody and said, see, look at this. This fellow has done a good carving, right? The third time you do a carving, the teacher calls all the third years and final years and says, this PG is doing wonderful carving. Then you really realize that you are a big architect, right? You keep doing something again and again and again. It just becomes a habit. Aristotle has always said this, something which just you keep repeatedly, you do something, right? Excellence is just habit. You do something again and again in the most excellent possible way. It just becomes a habit. So behavior shaping is exactly the same thing, right? You kept doing something, somebody kept praising you. So it became a desired behavior. You had to do this desired behavior again and again. You keep doing the desired behavior again and again. It comes into being. Successive approximation of the desired behavior until the desired behavior comes into being. That means you keep doing something over and over again till it actually becomes you. And then you keep doing it and it becomes an art. Right? So it's just a small thing. When I say behavior shaping, can somebody tell me what theory, which psychology theories could be related to behavior shaping? The child is getting used to something. The child is getting to do again and again something. He's getting adapted to something, right? So Pavlov, yes. Conditioning, positive reinforcement, fantastic. So all the laws of learning which I was speaking yesterday will obviously fit into all your behavior management techniques. So I'll give you one last slide where I'm sure you would have seen because I've already given you the slides. You would have had one table or column which shows all the behavior management techniques will be based on this particular theory, right? So successive approximations, you keep doing it again and again and again. The person gets used to this. Instead of using the word used to, I'm going to say the patient gets conditioned to this. So conditioning is like behavior shaping. So behavior shaping is conditioning. Conditioning could be classical conditioning, operant conditioning, or social learning, right? So it could be the way you condition yourself, right? Okay. So the fundamentals of behavior management, 6 fundamentals of behavior management, which you must read definitely from McDonald, nothing else. So positive approach, team attitude, organization, being truthful. I would say this is the most important. If you're going to extract, you tell the child you're going to extract. If you're going to give an injection, tell him you're going to give an injection. But how are you going to give the injection? You tell him in the most pleasant way you can put it, right? Be very, very truthful. The child can only see black or white. There are no gray scales in between. Whenever you are, when our teacher asks you a question, right? We beat about the bush, right? We always talk in gray scales. They say bullseye answers, please. Postgraduates, you must be to the point. They want black or white. Children want black or white. Don't beat about the bush. Be very truthful. Tolerance, right? Patience. How much patience do you have? How much tolerance you have? If you really want to check, that means you have to work with patience. You have to be very flexible, right? You think you're going to do pulpotomy today, the child cooperates, you do pulpotomy and crown. You think you're going to do pulpotomy and crown today, the child will only allow you access opening when if you place a pharmacrosol pellet and give a temporary filling and send the child back again. Still possible, right? So flexibility in planning is very important. PINCAM. In PINCAM, you have a specific domains in behavior management. If there is an essay question, I want you to write your domains like this. A linguistic domain. When I was the word linguistic domain, yesterday also I kept using the word linguistic in psychology. So what does that word mean? What kind of domain are we talking about when I say linguistic? Language, yes, language. So what am I talking about? What is the best behavior management? If you ask me, what is one topmost behavior management, what would you say? If I asked you guys, after 3 years of PG, only one behavior management you must use, what would you use? Tell Shodu, communication. Yes, fantastic. Communication. Communication is the key. Communication is the key. Linguistic domain is communication, right? Reward oriented could be gifts and rewards, no bribes, nothing given prior. It is always earned later. That is a reward, right? Aversive domains, all your aversive conditioning, hand over mouth, exercise and all that. Physical domain, your physical restraints. Pharmacological domains, which we have 2 more speakers to be talking about that, right? So that's what it happens. So please write this particular thing. APD gives you like this. APD gives you like this. Basic behavior guidance. This is, I'm sure, definitely both the speakers are going to talk about this. Nitrous oxide sedation used to be pharmacological behavior management. We used to call it pharmacological and non-pharmacological, right? I'm sure all the teachers here have been taught like that, right? Even I still try to do non-pharmacological behavior management. But that's not how we do. We have to use basic behavior guidance, advanced behavior guidance according to AAPD. Under basic behavior guidance, they brought nitrous oxide. Nitrous oxide cannot kill anybody. So nitrous oxide comes under basic behavior guidance, right? So advanced behavior guidance includes protective stabilization. So what is protective stabilization? Protective stabilization, medical immobilization. What is that word? Anybody? Protective stabilization. Okay. When I am going to stabilize somebody, whom am I going to stabilize? They have physical restraints. Yes. Why do you think the word physical restraint should not be used? Anybody? Why should the word physical restraint should not be used? Physical restraint, again, it's a very, very, very tough word to use on children. I don't want to physically restrain somebody. If I am going to use posy strap on all of you and say, okay, I'm going to talk for another 1 hour, all of you better stay strapped to your chest. That is what behavior management would do. That's what physical restraints would do. Right? I'm going to ask you lie down comfortably, protectively stabilize yourself and listen to something I'm talking here. Right? So protective stabilization, protection to both the operator and the patient. Please remember, it's both to the child and to the dentist. Right? Thumb guards, right? Mouth props, right? Some mouth props are not allowed these days, so you have to be a little careful on the use of molds mouth prop these days. Okay, let us come to communication. If I ask you one favorite question, I would ask you, I will say communication. I can ask you communication 25 months, right? Communication is something very, very big, but I want you to understand predominantly communication is non-verbal, right? If somebody is able to convey whatever they feel to you, I am the sender, you are the receiver, and I'm using a medium which is language, right? So I'm using some words that is verbal, but the tone, the intensity, my facial expressions, my movement, my appearance, my gesture, my posture, all that is 65%. If my communication is successful, it is only because I'm using non-verbal communications. Though it's an online, I'm not able to see. If I was live there, I would have tried to establish eye contact with most of you. Even if it's not possible, we would still try to look at the camera and try to change our facial expressions, the tone, the pitch, the intensity, so that we can communicate better. So you have to really master this. Always we tell children, I tell the postgraduates, please do vocal anesthesia, right? Vocal anesthesia and not local anesthesia. More than local anesthesia, vocal anesthesia will always work, right? Okay, there's something very important which I purposefully missed there because I think we have time constraints here. So look at this, invading into someone's space. Please understand, I told you intrusion. There are 5 reasons for dental fear according to Chapman and Kirby-Turner. But the 5 reasons of dental fear, the most important thing I would say is invading into somebody's space. I told you intrusion into personal body cavity, which could be eye, ear, nose. Apart from that, you are working at an intimate distance, right? You are working at a very close distance. Imagine you go to a shop, you stand away 6 feet away from the guy who's the shopkeeper, right? Nobody stands 2 feet like this. Nobody puts your hand into somebody's mouth. Nobody sits close to the face like that, right? So we are the only ones who invade into somebody's private space, right? We are very, very close to them. We are touching them all around. So you have to be really, really careful. The closeness is something which you have to be very, very careful. A smile, a wink, a handshake, a pat on the shoulder, everything would work. Facial expression. Tell me where facial expression works best. Because I'm not going to teach you tell, show, do or anything. I might tell you one point in everything and I'm going to finish. Tell me where facial expression works best. If somebody tells that, I would really say that person understood that particular concept well. One, behavior management, where facial expression is the most important. Facial expression is most important. Okay. If I have any answers, yeah, I'll give you a clue. Let's say satta to a child, okay? And if I say satta, okay? If I smile at the child and say satta, sattam bodada, don't make noise. And if I say don't make noise, which works better? Fantastic. Voice control, that's it, voice control. Voice control does not work with voice. Please remember, voice control does not work with voice. You can say chattam, you can lie, smile and say voice control, it's not working. It is change in intensity, pitch, voice, yes, but it is called implicit control because it works on the facial expression. So facial expression is again communication. So if you ask me which is the best behavior management, I will say temper tantrums, apprehension, fearful child, you always come back to communication, right? Okay, let me go back and try to give you one more word from everything. Okay, Greenbaum, 1993, touching the child, right? 7 to 10-year-old child, if you touch them, it's good. Bend at the child. Look at me. I'm 6 foot tall, right? I would look like a giant to a 5-year-old child. It's just not going to be possible. You have to sit at eye level contact, establish communication, multi-sensory communication, message should be clear. Second language, which is called euphemisms. Problem ownership, obviously problem ownership. Don't say you are not cooperating, you are not cooperating. You always tell the child, I am not able to do it. I am not able to see. I'll always tell the child, uncle, look at uncle, I'm wearing a spectacles. I'm not able to see. Then he says, poor guy, he's probably blind. So I will just open my mouth. Problem ownership will always work. Active listening, right? You always listen actively. If I say chat, and all of you who are all sleeping are looking, what does this guy do? If you reflexly turn towards me, it is hearing. If you are saying, what is this guy? All of these guys are telling that this guy is very good in behavior management. Let me see what he's doing. If you voluntarily try to listen to what I'm saying, it's actively you are listening, right? Listening is voluntary. Hearing is reflexive. In pediatric dentistry, you must master listening because listening is the key to communication. If my communication, if you say I have given a good lecture, okay, the good lecture will be a good lecture only because you are all listening. If you think you are only hearing, then my lecture is a failure. My communication is failed. My communication is to make you listen, right? So listening with children is very, very important. Scheduling appointments, using appropriate responses. Tell Shodu, cornerstone of behavior management is the only thing effective about 3 years. Contingency management, I purposefully did it yesterday because I know I will not have time. Contingency management works on. Please put the answers on the chat box. Contingency management works on. Okay, I just have another 5 minutes. We started at 7:35. So somebody can tell me contingency management works on which learning theory? Yesterday I told you pleasant stimulus, unpleasant stimulus, stimulus, response, consequence, right? So that means stimulus, response, and consequence. If the child wants something, you give him. If the child does not want something, you take it back. Yes, it's operant conditioning by B.F. Skinner. Yes. Distraction, one where there is no contraindication, you can always do some magic, abracadabra, right? It's always distraction is the best. Lots of articles on distraction. You have active distractions, you have passive distractions. Where the child actively participates is active distraction. Where the child passively listens to music or watches television is passive distraction. I have given you the slides there. Retraining includes ADD, avoidance, de-emphasis. Avoidance is taking away. The child does not want extraction, I avoid the extraction. The child does not want the high-speed handpiece, I substitute the high-speed handpiece. So avoidance and substitution would fall under some learning theory. Which learning theory? The child does not want something, I take it away. The child does not want something, I substitute it. So under which theory would it come? Operant conditioning, yes. Negative reinforcement, fantastic. Right. Distraction was the other thing. ADD is collectively called retraining. Retraining the child happens with avoidance, de-emphasis or substitution, distraction. Modeling or behavior management can start at home because in Western countries, we give an appointment. The email is sent. The child is asked to look at the emails from home. And this is called as pre-appointment behavior management. Yes. Then, okay, where is that? Voice control, I told you, sudden intensity, pitch modified, but the most important thing is the facial expression. Okay, Evangeline Jordan, Kramer, Levitas, fine. Why should it be used only between 3 to 6 years of age? That's my question. Why should it be used between 3 to 6 years of age? A child who is less than 3 years of age will get scared. If you put your hand over the child's mouth, that means he's going to say, okay, he's going to panic more. A child less than 3 years of age comes under dash classification of right. Some answers, please. Fantastic. Lacking cooperative ability. So if they're lacking cooperative ability, I can't put my hand over the child's mouth. I can't do that. If you do it above 6 years and 7 years, what will happen? Try holding a child at 6 years, 7 years, 8 years, maybe 10 years. Try holding a child. He'll kick you. He will lash out his extremities. You're going to be, yes, you're going to be bitten. You're going to be hit. You're going to be kicked on your face. So don't do it above 6 years or 7 years of age. You should only use it for 20 to 30 seconds. Airway should not be restricted. Modifications are airway restricted with towels, without towels, and stuff like that. Okay. Physical restraints, I told you. Medical immobilization, protective stabilization, mouth props. The name of the bite block which you use. Name of the bite block which you use. What is it called? The black bite block which you use. What is it called? Something to do with your burgers which you eat. Starting with that, let us. Okay, molt is not the one. Molt is the reverse scissor action, like the Ferguson's mouth gag, right? It's Meccasin, right? Yes, Meccasin is the right word. Physical restraints. When you're using physical restraints, please remember all physical restraints should not be done with one person. One person holds the hand, one person holds the legs. Which part of the leg should you hold? You tell me this. Which part of the leg should you hold? fantastic knee. Because if you don't hold the knee, the child will always start kicking out, lashing out. Okay, very good. Okay, so hold the knee, one person for the head, then you have passive physical restraints. This is my summary. All your behavior management techniques summarized with different names. Yes, I would think I will stop there. Yes. I just gave you a little bit more on children with special healthcare needs, but I don't think I should do that, but it's just an added thing. Only with children with special healthcare needs, please remember, repetition is the key. You keep repeating things over and over again, but everything will work. Tell Shodu should work. Everything will work. So please don't think all children with special healthcare needs should be taken under sedation. All special children with healthcare needs should need general anesthesia. No. That's exactly why I put a little bit of slides for you. I know I will not be able to touch it. So that's why I gave you the slides before. And thank you so much, APPD Kerala State. Thank you so much, Suresh sir. And is sir there? Yeah. Thank you to the moderators and to the association. Thank you for this opportunity again.
Thank you, sir.
Yeah. Again, I wanted to stick to time, so I didn't want to overshoot. Yeah. Thank you, sir.
Now next, I think Dr. Verma will be introducing. Questions we'll be taking last.
Yes, sir.
Hello, can you hear me? Am I audible?
Yes, sir.
Okay. I have pleasure indeed to introduce my dear friend, Dr. Sunil Muhammad. He did his BDS from Maharashtra. He later completed MDS in pedodontics in 2001 from Davangere. He has been into clinical practice as well as academics since then. He has held positions as secretary and president of IDA Kundangulam branch. Along with me, he was secretary of APPDK when I was the president. He has been a keynote speaker and has given hands-on trainer sessions on conscious sedation at the national level. He has been present at ABCD of NOIS during the national level CDE by IDA Kerala State and Pierre Foucault Academy. And he has moderated in symposium on sedation and anesthesiology in dentistry in the Indian Dental Conference in the national level held at Kovalam. And he has presented many lectures in IDA branches all over Kerala. And he has been instrumental in popularizing conscious sedation in Kerala. Over to you, Dr. Sunil Muhammad. Dr. Sunil?
Yes, sir. Yes, sir. Screen share, you can share. Now, I think Sharath has to stop sharing, then only I can continue sharing my contents. Sharath?
Hello, sir.
I think you need to stop sharing, then only.
Oh, okay, sir. Okay, sir. Sorry, sir.
Please.
Sorry, sir. Sorry, sir.
It's
I didn't realize that. I was looking at you and I was looking, where's your slide? Sorry, sir.
Perfectly fine. Am I audible?
Yes, sir.
Am I audible?
Yes, sure, sir.
Okay. Shall I start with my session?
Yes, sir.
Please go ahead.
Okay. Good evening, everyone. With due respect to the senior members, students, and my dear friends, I'm so very happy and excited to be a part of this APPD platform. But at the same time, I'm sort of anxious and tensed because I'm presenting in front of exam going PGs who are really well versed with their subject. I'll attempt to narrate my topic like how a kid narrates a story, and I'll try and put the maximum effort to justify them. Now, the major question asked us, is nitrous oxide useful in the industry? Nitrous oxide is known to mankind since 200 and odd years, and still we dentists are reluctant in using it, or rather we are refusing to use this. So the questions which arises here is, why are people so scared of dentists? So the right answer which I thought of saying is, it's simply because during our young age itself, parents do tell children, you have chocolates, we'll take you to the dentist. You have ice cream, we'll take you to the dentist. So dentist is always presented at par to a terrorist. So a resource person should always be presented in a respectful manner, and that's a great change which society needs to do. This has to happen globally. And why dentists are so scared of conscious sedation? Maybe the reason is we have heard of many incidents happening in different parts of the country. And the true fact is, not even once you could blame nitrous oxide as the culprit. It is always combination of things, or some other mistakes happened in other forms of sedation, not for nitrous oxide inhalation sedation, which is one of the safest, and it holds such a track record. Not even one fatal incident is recorded on nitrous oxide. Now, the other questions which is commonly asked along is, do we really require an anesthetist? The answer is, as a matter of fact, you are using a least potent gas which cannot do any harm to a person. So the fact is, you don't require an anesthetist to use this. Now, many people were debating that it is all for pediatric patients and why use this. It's not for pediatric patients. 40% of the population, they do not attend a dental clinic because they are scared of an injection. They are scared of dentist. And you can actually invite those percentage of people who are refusing to attend the dental operatory by using these means. The word conscious sedation is always a controversy. It's an oxymoron. It is said that happily married, how can a person be happy if he is married? Same way, how can sedation and consciousness go hand in hand? So that was a debatable area. And nitrous oxide, the other name for nitrous oxide is laughing gas, which is colorless, odorless, but it gives it sweet taste. If the operator, if the leaked gas is inhaled by the operator, you get a sweet taste in your throat. Specific gravity of nitrous oxide is 1.53. Specific gravity being 1.53, it is slightly heavier than air. So what happens is, the leaked nitrous oxide, it can settle down in the operatory, it can settle on the floor. So we always require a good scavenging system and an exhaust fan at the floor level, so that the escaped nitrous oxide can be removed from the operatory and the operator need not inhale it chronically. The beauty of nitrous oxide is insoluble gas. So I put it as NOIS, NO for nitrous oxide and IS for insoluble. The beauty of nitrous oxide is it's insoluble in blood. It is carried in serum and it affects the brain, and it returns back without getting stored anywhere in the body. That's the beauty of nitrous oxide. And the other beauty part of nitrous oxide is metabolism. Nitrous oxide is not metabolized by the body. Nitrous oxide is not metabolized by the body. It is straight away inhaled and it is exhaled through the very same lungs. and only very small part of it, 0.004% only is metabolized by the body. And there is no allergic reaction whatsoever mentioned about nitrous oxide. We have never heard of a person who's allergic to oxygen. We never heard of a person who's allergic to carbon dioxide. Same way, there is nobody who's allergic to nitrous oxide. And when nitrous oxide, it is gas at room temperature, but when it is compressed in the cylinder, what happens is the gas portion comes on top and the liquid portion fills it. So while using nitrous oxide, a full cylinder shows 750 psi as the meter reading. Whereas when the cylinder is half empty also, the meter reading is at 750 itself, because the gaseous content comes on top and the meter reading is shown as the cylinder is full. So we need almost the cylinder to be empty for the meter reading to be shown as 0. So nitrous oxide reading cheats. Nitrous oxide reading is not proportional to the content of nitrous oxide present in the cylinder. Whereas when you look at oxygen cylinder, a full cylinder of oxygen, it shows 2000 psi, and a half cylinder shows 1000, and a cylinder which is empty, it shows 0, which means it's proportional to the content present in the cylinder. The best of qualities of nitrous oxide is titration is possible. Any drug which can be titrated means you can give it to the desired limit where a person is happy and enjoying, or the desired results you achieve. The other beauty of nitrous oxide is it produces analgesic effect. For majority of the people, it produces circumoral numbness. So when you inject, patient won't feel the pain of injection. And for the very same reason, anxiolytic property of nitrous oxide is what is more talked about. And for that reason, we are using nitrous oxide. And nitrous oxide, it enters into the lungs through the nose, it enters into the lungs to the circulation. And once you stop nitrous oxide, the whole of nitrous oxide is thrown out. So you have rapid recovery, no cognitive effects last. It's the minute, the second you stop nitrous oxide, the remaining nitrous oxide is thrown out. You can drive back home. You don't need an assistant. But of course, for children, we require the parental presence in the operatory. Now, amnestic property of nitrous oxide, which is another beauty, in which the patient won't remember the incidents or the time factor. So long appointments for the if procedures of long appointments, the patient feels as if, oh God, it got over so fast. That is all because of the amnestic effect. And at the same time, suppose you're doing an impaction, when you're using more of pressure, patient might show ooh, ah, and ouch, but they will not remember the incident, and they comment as if, oh God, it got over so fast. That's another beauty of nitrous oxide. And minimal side effects and rapid onset of action. A rapid onset of action of nitrous oxide is simply because of insolubility. So we said NOIS, NO for nitrous oxide and IS is insoluble. As nitrous oxide is insoluble in blood, action is seen fast. Within 3 to 5 minutes, you get to see the action. There are various uses of nitrous oxide, like one is recreational use. It was used once upon a time in light parties, in great gatherings for enjoyment purpose, which is not used now. Secondly, industrial purpose as an oxidizer for rocket engine and automobile engines for improving the performance of the engine. And it is used as a propellant of dairy products and foaming agent. So these are the uses of nitrous oxide, and also it is used for inflating the automobile airbags. Coming to the composition of ambient air, we have 21% of oxygen present in the normal ambient air. Our equipment is equipped with delivering minimum of 30% of oxygen. Internet connection is unstable. Okay. So 20 atmospheric air has 21% of oxygen, whereas our equipment at any given point of time will deliver a minimum of 30% of oxygen. That adds beauty to the equipment what we are using. Now, the other questions which is generally asked about this is, can we knock out someone? Can we make a person unconscious? Theoretically, no. Simply because any gas to knock out a person, it requires a certain percentage of gas to be used, which is called as a Mach value. And nitrous oxide needs to be given at 104%, 104% to knock out someone. And our equipment can deliver only 70%. So theoretically, you cannot knock out. But at the same time, if a person has certain conditions like bipolar disorder or a person who is a hyperresponder, for them, it can hit fast and the person can be taken to the next level. But there's nothing to worry, simply because I take Dr. Srinivas Namnini sir's words here. You shoot, you use your gun, but anytime you want to retrieve your bullet, you can't do that with this equipment. That's the beauty of this equipment. And the other question is, can we avoid the use of local anesthesia? No, we have to give local anesthesia. The only thing is, anxiety is taken care of. So anxiolysis is achieved and analgesic effect is present. But to have better analgesic effect, you need to give local anesthesia. So local anesthesia is mandatory. You just cannot avoid local anesthesia. The beauty of nitrous oxide is it does not hinder the protective reflexes. The cough reflex and the gag reflex remains intact. Now, larynx is the first line of defense mechanism. If a foreign object moves towards the larynx, cough reflex is initiated and the object is thrown out. Suppose an object bypasses the first line of defense, then carina, the neurologically rich sensitive area which is present at the bifurcation of the lungs, it acts well and cough reflex is initiated and the material is thrown off. So a person who is under nitrous oxide sedation, and if you're using your air rota handpiece, water coolant, will the patient aspirate? The answer is no, simply because the protective reflexes are intact. But at the same time, we need to be careful, because we should be careful that we don't take them to the next levels of sedation. But generally, it doesn't happen. Theoretically, it doesn't happen. Joseph Presley, while working on sulfur, iron, and water, he came up with two gases. One, he called it as dephlogisticated nitrous air, and which was later termed as nitrous oxide. And the other one, he named it as dephlogisticated air, which is good for breathing, and that is presently called as oxygen. And Humphrey Davy, at the age of 21, even after knowing he is playing with potentially dangerous gases, he went on experimenting with it, and he was conducting roadside shows and so on. He was the first one to find out that there is decrease in toothache, and the dental profession drug has the analgesic effect after 40 years. His words was not taken very seriously those days. Later, Gardner Colton, he conducted a grand exhibition at Connecticut, and Dr. Horace Wells, a dentist, so he is the man behind nitrous oxide, Horace Wells. That name is very, very important for us. Horace Wells, he didn't want to be mere a spectator. And during the show, a person named Cooley, he was given nitrous oxide by Dr. Gardner Colton. And out of anxiety, or rather out of happiness, Cooley started jumping and dancing on the stage. And he got a deep laceration on his leg and it started bleeding. He was unaware of the cut and he was still dancing on the stage. This was noticed by Dr. Horace Wells, and he thought of doing experiments with this gas because of the analgesic effect. It was Gardner Colton who taught Horace Wells to prepare nitrous oxide, and Dr. Horace Wells did experiment on him. Dr. Riggs, one of his friend, he extracted Dr. Horace Wells' tooth, and they exclaimed like, later on, ether came into existence, and then later chloroform. Chloroform had very well acceptance because people could self-administer it. Soldiers were happy in using it. And our great man, Horace Wells, of course, I forgot something in between. Horace Wells in 1845, he was given a chance to perform in Boston. That is, he was a man who was teaching everyone about the importance of the analgesic effect of nitrous oxide. And during his performance in front of physicians and other doctors, he was doing an extraction of a patient, and the patient jumped from the chair, and everybody thought Horace Wells is faking, and he was criticized badly. Upon questioning the patient, he exclaimed like, I just jumped, I didn't have pain, but then nobody took it. And Horace Wells was in deep trouble. Later, he became a chloroform addict, and in New York City, he threw acid on a prostitute, and he was behind bars. And this great man, he committed suicide in the jail itself by using chloroform and the razor which he took from home. He died at the age of 33 without knowing what his life kept happy for him, the fortunes kept by life. Dr. Edmund Andrew, he was the one who added oxygen to nitrous oxide, and he claimed that 1/5 of the content should be oxygen. And it was Frederick Hebeth who incorporated oxygen into the machine. And it was in late 1970s, the oxygen flow, which was not demand flow, which was given with a regular flow of oxygen, with the equipment was delivered, and using machines, which was before 1970, is unfair. We have different means of managing pain and anxiety, right from communication, our skill in communication, which can be called as the iatrosedation or sophrology, to inhalation sedation. All this area, the patient remain conscious. Any issues? Anandraj, I hope I'm audible.
No, sir.
Yes.
Audible.
Yes, sir.
I'll continue.
Okay.
Fine. So now here you have no anesthesia to inhalation sedation, wherein your attitude, your behavior, your smile, your gestures, all those matters for the patient. Even that acts as something called as the sophrology or iatrosedation. And using inhalation sedation, you cannot skip any of these. It's not that on a cranky child, you just give nitrous oxide and you're successful. No, your behavior management techniques still remains the fundamental. Your communicative skill still remains the fundamental. And to add to it, you can use inhalation sedation to make them much happier. Now, conscious sedation, there are minimal sedation, moderate sedation, and deep sedation. Conscious sedation is actually pharmacologically induced minimally depressed level of consciousness that retains patient's ability to maintain a patent airway independently and respond appropriately to physical stimulation and or verbal command, which simply means the patient can breathe on his own. You tell him to lift his hand or leg, he will. So like he is conscious. Now, what is the major difference between minimal, moderate, and deep sedation? In minimal sedation, you just tell him, lift your hand, he's going to lift. Whereas in case of moderate sedation, you might have to do a bit of a pat. You might have to do a bit of a pat, then only he will realize like, yes, the command is given. So in moderate sedation, you require a light tactile stimulation. Whereas in case of a deep sedation, the patient, either you need to create a painful stimuli to a verbal command. Second one is a light touch. Third one is painful touch or painful. Now, the beauty of nitrous oxide is it eliminates anxiety. So anxiolysis is what we really want to achieve. It enhances communication and patient cooperation. Now here, I'll make it very clear. During nitrous oxide, giving nitrous oxide, you need to communicate with the child. The child needs to be a bit cooperative to be ready to place a nasal hood on his nose. Then only you can. Now here, communication doesn't mean you keep talking to the child. Once you give nitrous oxide, it's lip sealed, no communication. Always talk in sign language. Now, as the pain threshold is increased, injections is no longer painful for them and they won't realize the injection. And reduce gagging. Now, a person, there are children or there are adults who really have problems with gag. You just cannot take an impression. So the best thing is you give nitrous oxide and you take impressions. It's much easier. The best of advantage for nitrous oxide is it's easy to administer. It's quite easy to learn. Only thing which you need to master is titration. Titration is something which you cannot learn swimming online. Same way, titration, you need to use it and learn titration. And that's it. By learning the right titration, you can use it. Anybody can use it. And the rapid onset of action. Now, if I ask you how and why there is a rapid onset of action, the answer is it is insoluble. As it is insoluble in blood, it's carried in serum. Secondly, the partition coefficient, it doesn't settle anywhere. Equilibrium is achieved fast and the action takes place fast. And it is not stored in the body and it comes out fast. So rapid onset is because of the insolubility. Nitrous oxide is non-irritating, colorless gas, faint, sweet taste, rapid uptake and elimination of nitrous oxide. Now, as I said, through the nose, into the lungs, from the lungs into circulation, it affects the brain. You stop nitrous oxide, that means the portal of entry is through the nose. From the nose part, when it is switched off, whatever is present in the body returns, flushes back into the lungs, and it is thrown out. Fast recovery because it is thrown out fast. Wide margin of safety because 104%, whereas any other gas, what we are talking about as anesthetic agents, GA agents, it's all with a minimal margin of safety, whereas this one is wonderful. And nitrous oxide is cardiotonic because any problems in the heart, cardiac problems, you can give nitrous oxide. And respiratory issues for asthmatic patients, you can give it because most of the time asthma is precipitated because of anxiety. And as nitrous oxide takes care of anxiety, you can aramse give nitrous oxide. No preparation of the patient is required. Simply by saying nil orally is not mandatory, but the only problem is when you are taking the patient to mild and moderate sedation, that's true. But if you go further ahead, it is difficult. So nil orally, it's like fine if your titration is proper and the patient can drive back home aramse. The major disadvantage, the first one what I have given is the lack of potency. So do we say lack of potency is a disadvantage or an advantage? Truly speaking, for a dentist, lack of potency is the advantage. Whereas for the medical profession, lack of potency is a disadvantage because they cannot do surgeries, or the consciousness cannot be like the GA effect is not achieved by using nitrous oxide is their problem. And we are really scared of unconscious patient, and we don't want the patient to be unconscious. And as our dear friend, the nitrous oxide is least potent, we are safe. Now, dependent largely on psychological reassurance simply means any cranky patient, you just cannot place the nasal hood and say, yeah, everything is going to be fine. No. You need to pacify them. You need to talk to them. You need to make them understand. And they should be willing to place a nasal hood on the nose. Then only nitrous oxide can work. So what is said is, during crying or cranky behavior, your heart rate goes up, your cardiac output is more, and more blood flows into the circulation with less gas. So you won't get the amount of, or the sort of anxiolytic effect what you really wanted to achieve. Now, interference of the nasal hood with injection of the anterior maxillary region, it's not a big issue. It's like you can always do it arams, but it's given as a disadvantage. Now, coming to the indication, who is it really indicated for? It is indicated for now. Sharad sir so well explained about Wright's classification. Wright's classification is also otherwise called as clinician's classification. Now, it is divided into cooperative behavior, lacking cooperative ability, and potentially cooperative. Potentially cooperative children, they are the ones who have the potential to cooperate. Then why are they not cooperating? It is simply because of fear and anxiety. And those are the children whom you can manage by using nitrous oxide. It is beneficial for them. Now, majority of the places, what happens is those children are taken under GA. So the table should flow like this. Now, without non-pharmacological behavior management, if that doesn't work, then go for pharmacological behavior management. Out of that also, nitrous oxide inhalation sedation, IV sedation. If nothing works out, then the last choice is GA, and the GA should never be taken as a first choice. Now, for a cooperative patient undergoing lengthy procedure means nitrous oxide will always it'll always give amnesia effect, and they will lose the count of time, and they feel as if the procedure got over so fast. So gag reflex can be altered. This is one study for that. Now, there are many areas wherein you should not be using nitrous oxide. First one being chronic obstructive pulmonary diseases, COPD. What happens is your respiratory drive, oxygen drive, wherein when you give more of oxygen, the request for the next breath is not given and the patient lands up in trouble. So it is wise to avoid in COPD. Upper respiratory tract infection, or if a person has blockage of the nose or congestion in the nose or polyp, a person who cannot breathe through the nose, it's a definite contraindication for the use of nitrous oxide. A person who had a recent middle ear surgery or tympanic membrane graft, what happens is this nitrous oxide moves inside the ear, and as the partial pressure of nitrous oxide is more, it is 31 times more than that of nitrogen. It increases volume and gives too much of pressure in the ear, and it can really cause ear problems. First trimester of pregnancy, truly speaking, nitrous oxide is not absolutely contraindicated. But then we do say we are not supposed to take radiographs. In good old days, pregnancy, they used to diagnose by taking radiographs. But chronic exposures are bad. Same way, nitrous oxide used during the first trimester of pregnancy, there can be issues told by others. So it's better to get ourselves away from it and not to use nitrous oxide. Drug, which is used in treating cancers, this can cause cystic fibrosis and create issues in the lung. So it is better to avoid. Now, nitrous oxide anesthesia should be avoided in patients who had undergone vitreoretinal surgery, that is surgery in the posterior compartment. It is better we don't give nitrous oxide simply because the gases, they leave an air bubble to keep the retina intact or closed, and nitrous oxide can blast this air bubble and cause blindness. So one other important aspect with this is such patients who had undergone vitreoretinal surgery should not be traveling by aeroplane. So aircraft should be avoided for some time. Nitrous oxide avoided in immunocompromised patients as it affects chemotaxis. And repeated exposures of nitrous oxide can produce leukopenia. So better to avoid, give an interval time. Now, it can clearly be given in case of asthma. And one study, which actually I found it from one of our presenter, who said that nitrous oxide is contraindicated in severe asthma. So there are studies for it and against it. Pharmacodynamics. Now, D for dynamics and D for drug. So dynamics is what the drug does to your body. Dynamics is what the drug does to your body, which means it is inhaled, it goes inside, then effects takes place, metabolism, excretion, all this flows into the topic of dynamics. So dynamic is what the drug does to the body. Now we know that it is least potent of all inhalation and general anesthetic because it is the MAC value being 104, it cannot act much. Drug potency word is important. MAC, minimum alveolar concentration. So alveolus means we are talking about the lungs, which means we are talking about inhalation agents only. Now, any inhalation agent which can produce an anesthetic effect and the patient is kept standstill without moving during a surgical procedure, the percentage of drug required to immobilize a person when doing a surgery, that is MAC. And MAC value of nitrous oxide is 104%, and our equipment can deliver only 70%. That's the beauty of nitrous oxide. Now, let me just present few terminologies for you all. One is tidal volume. Tide, what we know is the ocean tide. So this is again something related to the ocean tide. That's why it is called as a tidal volume. So here it is the regular ebb and flow of air in and out of lungs in a normal quiet respiration. Means when you simply respire, a feather kept in front of your nose, it doesn't move. So that is the quiet respiration. So tidal volume is the regular ebb and flow of air in and out of lungs in a normal quiet respiration, which is equal to 450 to 500 ml. So tidal volume is 450 to 500. Let's take it as 500. Now the next one is minute volume. Minute volume is tidal volume multiplied by number of respiration per minute. Number of respiration per minute is 12 to 15. So tidal volume being 500. So 500 into 12 is equal to 6,000. 500 into 12 is 6,000 ml, which is equal to 6 liters. So the minute volume is something we adjust on the equipment. The amount of oxygen given when you start delivering nitrous oxide is what we are talking about. You turn and give the flow control valve, you turn and you give oxygen first. So the oxygen is adjusted at 6 liters per minute. There are other means of calculation also. It is said that it is 5 to 7 ml per kg. 5 to 7 ml per kg and multiplied by the tidal volume. That is again another calculation for minute volume. And MAC value of drugs is given like this. Now to remember the inhalation agents, DESI, now this is Desi on a national highway, NH. Desi on a national highway. Desflurane, enflurane, sevoflurane, isoflurane, nitrous oxide and halothane. Just look at halothane. You give 0.75% of halothane and the person is knocked out. It's very potent. Whereas nitrous oxide, you require to give 104% of nitrous oxide to knock out someone. And the beauty is our equipment can deliver only 70%. So theoretically, you just cannot knock out someone, and we are playing with such a safe gas. Now, when you use LA, we are supposed to give test dose. Many of the physicians and surgeons, they are scared in using LA, and they really surprisingly, shockingly, they say, how few dentists give so much of local anesthesia without test dose? God's grace, God has always protected us. Nitrous oxide, it's even safer than any other drug with no issues so far. It's very safe in the hands of the dentist. So we can use it and let's make use of it. Now, pharmacokinetic is what the body does to the drug. Pharmacodynamic is what the drug does to the body. Now, am I audible? Anandraj?
Yes, sir. Yes,
okay.
yes.
Fine.
Yes, yes.
Okay. So now coming to the partial pressure. Now, partial pressure, any gas, combined pressure is present, out of which the individual gases produces a pressure which is called as a partial pressure. The combined pressure is 760 millimeters of mercury, and the individual gases exerts pressure. It tries to come out of it and produces pressure, and that is what is called as a partial pressure. And always gases always move from higher to lower pressure gradient. And this movement, so when you place nitrous oxide, it is given through the nose. So the nasal hood is placed on the nose. And once nitrous oxide is given, which means it is higher on the nasal end, and the gas moves into the lungs. From the lungs, it goes into the circulation, and through this, from the circulation, it goes through the circulation, it reaches the brain, and effect is taken. Nitrous oxide, once we stop giving nitrous oxide, what happens is nitrous oxide, which is present in the body, it gushes back into the lungs and it is thrown out through the nose itself, which simply means when you give nitrous oxide, more pressure is produced at the nasal end. And when you stop nitrous oxide, more nitrous oxide is present in the body, and whatever is present in the body, it starts flowing back into the lungs. And from the lungs, it is thrown out through the nose itself. Now, the figure on top shows that nitrous oxide, it has a partial pressure of 31 psi, whereas of nitrogen, which is present in the normal air, has only 1 psi. So what happens is, when this nitrous oxide moves into the ear or any other closed spaces, it increases volume and pressure, and thereby it can cause pain. partial pressure is always inversely proportional to the solubility of the gas. And nitrous oxide, insoluble or very low soluble, produces a rapid rise in the partial pressure. And the beauty is less soluble gases or vapors are less potent. Less soluble gas, less potent, but it acts fast. That's why nitrous oxide, it takes its action within 3 to 5 minutes. So a relatively insoluble gas like nitrous oxide, it's ideal for use in dentistry because we are scared of unconscious patient and we don't want that to happen. Now, solubility coefficient of nitrous oxide is 35 times higher than that of nitrogen, and it quickly displaces nitrogen. We said the partial pressure is 31 times more, and in blocked eustachian tube or blocked bowels or blocked sinuses, it increases the pressure and volume, thereby causing pain. So a person who has sinusitis, don't give, you can postpone the treatment. A person who has constipation, it can expand the bowel and cause pain. So postpone the treatment. Ear surgery, postpone the treatment. A person who has vitreoretinal surgery, postpone the treatment. It's not, you can't say it's contraindicated. It's better to postpone the treatment. There is something called as a second gas effect or eager effect. It is like you give nitrous oxide first, and after giving nitrous oxide, give the potent gas later, like sevoflurane, which is more potent. It is more dangerous also. So giving nitrous oxide first, sevoflurane or the other gases, the percentage of gas required will be less, and the toxic effects or the dangerous effects of the second gas is always reduced by using nitrous oxide as a first gas. This is called as a second gas effect or eager effect, EGER. Now, partition coefficient is the interaction between the drug, the brain, and other tissues till equilibrium is maintained. Partition coefficient of nitrous oxide between tissues, muscles, and fat is very low, and equilibrium occurs very fast. As equilibrium occurs fast, action is fast, and nitrous oxide, the beauty part is nitrous oxide not stored in the body, and it is easily eliminated. So that is the beauty part of nitrous oxide. Coming to bioavailability, it's right way of saying two friends sitting across the table to have whiskey. One friend is out with 2 pegs and the other fellow with 1 full bottle, 1 full kamba also, he is perfectly fine. Which means nitrous oxide for some at 30% it might hit. For other person at 70% also it might not hit. So there are people called hyperresponders, and so on. So the factors, you give nitrous oxide and your patient was hit at 40. It doesn't mean that the next day you give it at 40, it's going to hit. It's just that you need to note it down on the table that you gave 40. Next time, again, titrate and find out which is good for him, which level is better for him. So there is no set percentage which can be really written for a patient. And every day it matters, the very same patient, the very same day you can have the difference. So biovariability, it varies from individual to individual and for the very same individual on the very same day. So titration stands the hallmark. Now you need to actually teach them the idea of sign language. Means you should not allow the patient to talk much once nitrous oxide is introduced. So before introducing nitrous oxide, what is most important is you need to reassure them, you need to communicate with them, and you need to put them at ease by using our same techniques of iotrosedation and sophrology. Sophrology was coined by a Colombian psychiatrist, Alfonso Caicedo, which he says calms soothing, sweet voice you use, you talk to them, your body language, all this matters a lot. And because of which the cardiac output is less and you have more of gas. So now coming to the sign language, you teach them like at the base level, you are supposed to show your horizontal thumb in a horizontal level and say, yes, how are you? The answer is thumb in a horizontal level. And if you feel good, it's thumbs up. And if you don't like it, it's thumbs down. And this sign language is important so that the patient do not talk in between and they do not push the nitrous oxide into the operator's breathing zone. And also, by talking, there can be differences in the amount of gas which is inhaled, and it can cause sort of a roller coaster like effect. So always nasal breathing, no mouth breathing, and lip seal, no talking. There are various means of monitoring of nitrous oxide which is present, which can spill in our operatory by using infrared spectrometry, time weighted average, and with this, it's something like the dosimetry badge what we use, and we need to send it to the lab for reading. Now, if you think of, we are supposed to check our light cure gun, radiometers. Now, normally what happens is you buy once, and once the blue light comes off, you continue to use. But here it is good to have all this and measure it. But to tell you frankly, I don't. And I don't have one also. But then in the near future, hopefully, we'll be moving to all those. Coming to the equipment, the yoke stand is considered as a backbone of this. And we can attach 4 cylinders onto this. The yoke stand has wheels and it is portable, whereas you can have wall mounted units also. The color of the cylinder, the blue color cylinder is for nitrous oxide and white color cylinder is for oxygen. Nasal hood comes in various colors and various aroma also. Like from a baker, you can buy vanilla, strawberry, or whatever essence you want, and you can just put a little bit onto the nasal hood, and according to their whims and fancies, you can give them the aroma what they want. And the meter reading part, we spoke about it early, and there is something called as a flush button. You press the flush button, you give 100% oxygen immediately. Now, how you operate a vehicle, same way, to operate this nitrous oxide equipment, you have the flow control valve. Operate this flow control valve to give 6 liters per minute, and our equipment reading the oxygen side, the reading shows as 6. Now, the best way is ask your patient, is the air enough? If they say no, it's suffocation, you increase oxygen. In case they say it's too much, decrease it. That's other means of doing it. Like trial and error method of placing a stainless steel crown and vernier caliper method of measuring and using it. And reservoir bag, it's normally everywhere it is told about the reservoir bag, but then presently the ones what I'm using without the reservoir bag, because reservoir bag, they say 3 purposes. 1, source of additional gas, 3 liters. Now, what I personally feel is you have the flush button, you have the additional source of air with you. Visualize the patient's respiration by seeing the moving bag. Look at the patient's chest. Why you want the bag? Provide positive pressure oxygen in case of emergency. Just squeeze this bag and you can give around 3 liters of air to the patient. Same way, you can press the flush button and give it. Now, for the cylinders, to open and close the cylinders, what is important is to keep in mind, clock is to close. Clock is to close. So to close the cylinder, you need to turn it in an anti-clockwise direction. to close the cylinder, you need to close it in a clockwise direction. Clock is to close. Opening, anti-clockwise direction. So let's not confuse it. Clock is to close. Now there are special features of our equipment. Something like, first one is, even by mistake, you cannot fit nitrous oxide cylinder into the oxygen port or oxygen cylinder into the nitrous oxide port, simply because of pin index safety system. From the yoke stand, there are pins jetting out at the oxygen portal as well as the nitrous oxide portal. And the pins are placed in different measurements. So by mistake also, or even if you want to also, you cannot interchange and place the cylinder. And the same goes for diameter index safety system. This and this. Diameter indexes, you cannot interchange the nitrous oxide and oxygen tubes which are placed behind the equipment, which actually we don't need to remove, which is done by the manufacturer itself. But still, even they cannot make such a drastic mistake. Even if they want to make that mistake, they just cannot. And the major beauty of our equipment is fail-safe mechanism, which is also called as oxygen fail-safe mechanism, which means while working, if our oxygen cylinder is depleted, if our oxygen cylinder is exhausted, the machine automatically shuts off. The machine can operate only in the presence of 30% of oxygen. If the oxygen level is gone down, nitrous oxide alone will not be delivered to the patient. The machine automatically cut off, and through the inlet valve, patient gets atmospheric air to breathe. So with all this, we are so very safe in using this. Again, I take my guru's words. Dr. Srinivasanam Nini sir keeps saying, if you want to kill someone with nitrous oxide, remove the cylinder and bang it on his head. Otherwise, you just cannot do any harm to any patient while using nitrous oxide inhalation sedation. Pre-procedural fasting is required or no, it is still debatable. If you're using it on patients on minimal sedation or moderate sedation, you don't really require to use fasting guidelines. So fasting is not required, is also there, whereas it is always wise for the fasting and then doing the procedure, simply because we might get into the next stage if the titration is not done properly. So constant vigil during titration, if you're doing so, then vomiting and nausea will not happen. So titration is the key, and titration is something which we really require to learn. Informed consent, pre-procedural fasting, pulse oximeter, fine, place nasal hood, open cylinder in anti-clockwise direction, adjust flow meter, that is at 6 liters per minute. Either you can give rapid induction or slow induction, but rapid induction is not fair and patient might not feel good. So better to go for slow induction. Roller coaster effect, if a patient breathe through the nose and mouth alternatively, or if a person talks, or if a person laughs and giggles, they can have alterations in the level of nitrous oxide and have roller coaster effect. And diffusion hypoxia, fine. Internet connection is unstable. I hope I am audible. For nitrous oxide inhalation sedation, make sure he voids before the procedure, because at times the patient tends to urinate on the chair itself, or when they want to urinate, the procedure has to be stopped and then restarted. So always make sure they void before the procedure, and make sure they don't mouth breathe or nausea and vomiting. Lip seal, again, to avoid mouth breathing, and also patient throwing nitrous oxide into our breathing zone can be avoided. avoid contact lenses because the excess of air which is moving out from the upper portion, it can dry the eye and cause pain. Titration, I would like to say it as timed titration, because titration gives time. It's not that without giving time, you do it fast, it doesn't work. Now, initial from 0 to 30, you can move in 30 seconds or a minute. That's perfectly fine. Whereas when you move from 30 onwards, give minimum of 3 minutes time for the drug to act. So titration is a method of administering a drug in incremental amount until the desired endpoint is reached, where the patient is relaxed and comfortable. So which means you need to look at them, you need to observe them, and you need to find out whether the patient is comfortable and relaxed. Most of the time, what happens is, even when the patient is comfortable and relaxed, they might not agree, because they feel, if with this much gas, I feel so good, then little more is going to be even more better. So make sure you focus on, like the question is, how do you feel? How do you feel? Now, most of the time after giving inferior alveolar nerve block, our question is, where do you feel numbness? Same way, don't expect your patients to give you those symptoms, or don't ask them, are you feeling numb here? Are you feeling sleepy? Do you feel like floating? Don't ask such questions. Focus on how do you feel. And when they feel good, let them show thumbs up. And that is what we really require. And don't ever ask them, are you feeling these and these feelings, which might not happen, because these feelings are intense for some and insignificant for others. So symptoms varies. It is not the same for everyone. So constant vigil is imperative, as pleasant sensation may quickly become unpleasant. They might be really happy with the gas, but in a short while, they might feel like nauseating or vomiting feel, or something is troubling them. So make sure your titration is proper, and the main indication is always the eye. Normally in the beginning of the procedure, you tend to see the eye is following your hands, and later when you are slightly to the higher level, the eye becomes sort of fixed. But we don't require to give them so much. But of course, for a child who's scared, a person who's scared, you can take them to that level, give a and then take them down. Even that is perfectly fine. Sorry. Gödel has given stages of anesthesia. So stage is something like the airport. So stages is given by Gödel, and from the airport you take flight. So the planes is given by Langa. So this is something which many of them confuse. So stages, it's Gödel's, stage 1 to 4. And the plane, it's for stage 1 is where we work with nitrous oxide. We work with nitrous oxide on stage 1, plane 1 or 2. Plane 1 or 2. And the term relative analgesia was given by Langa. And this plane 1 or 2 is important for us, and we don't take them to plane 3. So plane 1, you achieve in 5 to 25% of nitrous oxide, whereas plane 2, you achieve in 20 to 55% of nitrous oxide. Plane 3, you achieve in 55 to 70% of nitrous oxide. And the factors, generally, for most of the patients, they get sedated between 30 and 50. Generally, the patients get sedated between 30 and 50. So that doesn't mean you straight away give 50. Now, after 30, you slowly increase, you take time, and then you increase by 10. That is always better. Now, this is from Mathewson. Now, at 40 to 60, you have dreaming, laughing, nausea and vomiting. Now, all this is seen at higher levels. Now, say 40 to 70, you can say. And for some, they just cannot move the extremities, their hands, that command is gone. Now, back in Pune, when I was with, like when Namnini sir was giving a demo, there was one student who really started screaming simply because at 30 itself, she was hit. And the next level, she could not move her hands or legs and she started crying. So what do we need to do? Decrease nitrous oxide. You have the equipment, you just give 100% oxygen and the patient will be fine. Now, even if you don't give 100% oxygen, decrease your nitrous oxide and the patient returns back to normal. That's it. You have the answer with you. So what if one deliver 70% oxygen? Now I have now in our demonstration classes, we give 70% to majority of the people and nothing goes wrong. They are perfectly fine. But that's not the case when you do it with your patients. You deliver it, you titrate in such a manner that they are happy accepting it. They're enjoying it. That is where titration becomes important. Now, sophrology, it's a term which is coined by Alfonso Caicedo, who is a Colombian psychiatrist. So he says that sophrology is a science of spoken word, which is soothing, calming, humorous, encouraging words of the operator, which facilitates a relaxing effect of the drug. And this is important because for nitrous oxide to act well, we need a patient who is relaxed. Of course, you can give it to patients who are cranky. Now, there are literature which says you give it on the mouth first with higher percentage of nitrous oxide. And when the patient calms down, then you decrease it and keep it onto the nose. But the best part is we have non-pharmacological behavior management, which we use it well. And then once the patient is ready to accept nasal load, use it. Never use fixed dose rapid injection technique. It's all trained clinicians do it, but it's better to titrate and give it. Avoid rapid injection. Now, it is said that at above 50%, there are hallucinations which happens for patient. And a case report was there in which the patient was sexually stimulated, feeling naked, dreamt and fantasizing. And there can be complaints against the dentist. So always better presence of a third party and appointments not in late hours. That will be better when you're using it on adults. Deliver 100% of oxygen at approximately 4 liters per minute for children and 6 liters for adults. This is what we were talking about, the minute volume. So minute volume is, we roughly calculate for 6 liters per minute. Now, in few children, it was found that laughter, which was difficult to control in 14% of children. And as nitrous oxide affects the tympanic membrane, there can be a hypernasal tone. And always those people feel that the operator stands somewhere far off and he's talking. And one rule is, you should never place a mouth prop in a patient who is under sedation, because if the patient is over sedated, they lose their control and they close their mouth. But once the prop is inside, that won't happen. So don't place a prop in a sedated patient's mouth. Or GA is a different story. Audio analgesia, it's wonderful to use. And nitrous oxide should not be used as a substitute to LA, rather it acts as an adjuvant. Now, even after giving nitrous oxide, when you're injecting, it's best to use topical anesthetic and then give your LA. Avoid nitrous oxide with other drugs, because that is the time when you have synergistic effect and things go out of your control. So when you're using nitrous oxide, it's wise to use pure nitrous oxide alone, not to use it with other forms of drugs. Now, psychological preparation is important, like proper communication and behavior management techniques is very important because relaxation helps to decrease heart rate and cardiac output. Now, low cardiac output means less blood which is pumped out, and this less blood will have the same amount of gas, whereas if the cardiac output is more, blood is more and the gas is less, so action is less. So you have fast and rapid rise in partial pressure, and nitrous oxide will be more effective, which means psychological preparation of the patient is mandatory before you give nitrous oxide so that your effect is enhanced. If a patient does not become calm within 3 minutes, then the success rate is quite less. But at the same time, like what we tend to do is we just tell the child, close your eyes and count to 50, so that we just distract them. But it works, at times it works. So best to consider 3 hours as an extended time of nitrous oxide sedation. And it is said that when you don't get the vein, a short course of nitrous oxide can enhance venous distension and visibility. So it's helpful for intravenous injection. Nitrous oxide can be used along with lasers. There's no contraindication for it. The use of inhalation sedation in local anesthesia is an alternative to GA for extraction children, which means if everything fails, then only GA should be used. Now, there are children, from their perspective, you were saying dreaming, headache. Now, headache can be because of not giving 100% oxygen after the procedure. Now, again, that's a controversy whether you need to give or no. Floating, warm and tingling sensation. Now, reading all this, you should not be asking your patient, are you feeling like floating? Do you feel like flying? No questions of that sort. Now, there are studies which says that in case of hot tooth, nitrous oxide is one great alternative. Whereas one study I found wherein which nitrous oxide increases the reaction time and reduces pressure-induced pain, which means when you are elevating a tooth, when you're doing an impaction, that pressure-induced pain, patient won't realize, it increases reaction time and reduces pressure-induced pain, which means for them to react, it takes a bit of time, but it does not affect pulpal sensitivity, which means pulpal pain still can happen. But the fact is, in most of the cases, hot tooth, the right means of treatment is do it under nitrous. Now, the major adverse effect with nitrous oxide is nausea and vomiting. It is because of longer administration of nitrous oxide for a long time, fluctuation in the levels. That means the patient breathes through the nose and mouth, or they talk, or they laugh. All this can affect. Lack of titration, you increase it and decrease it all of a sudden. All this can cause vomiting. Increased concentration of nitrous oxide and heavy meal prior to the procedure. Now, heavy meal, it's better to avoid, but at the same time, if you're titrating well, heavy meal is no issue. Diffusion hypoxia. Diffusion hypoxia is during termination of treatment using nitrous oxide. There is outpouring of nitrous oxide into the lungs and thereby decrease availability of oxygen. This is theoretical. But most of the patients, or rather, I find many patients complaining of sort of headache or slight discomfort. You can avoid all this by giving 100% oxygen. So there are studies in favor of diffusion hypoxia and giving 100% oxygen, and where you don't require to give 100% oxygen. But it's wise to give 100% oxygen so that the patient is happy. Now, the hazards associated with chronic nitrous oxide exposure is the reproductive problems is majorly seen, and it's all because of chronic exposure. So a patient with a thick mush, you need to be careful because your nasal hood won't fit in so well. So in that case, what you can do is place a piece of cotton underneath the lip, so the lip raises slightly up and the fit is snug. The nitrous oxide, it can cause pernicious anemia by reducing activity on methionine synthetase. So any case of pernicious anemia or megaloblastic anemia and all, it's better to avoid nitrous oxide. The occupational exposure limits is given by different countries, and still a proper exposure limit is not actually suggested. Now, Sweeney was another person who's done a lot of studies on this. Scavenging system. Now, normally the scavenging, or rather the nasal hood, what we use is a simple nasal hood, which has nitrous oxide coming from one port and the exhaled nitrous oxide thrown out from the other port. So here the issue is the nitrous oxide, when you fix a scavenging system is nothing but an vacuum suction, a suction which is kept, which can suck at 45 liters per minute, which can suck at 45 liters per minute. What can happen is here, the gas which is given for inhalation can be drawn out directly. Whereas when you use a double mask means a mask which has a compartment on top and the vacuum is attached to this compartment on top. So the inhaled gas, or rather the gas which is coming towards the nose portion, it is not sucked by the vacuum. The vacuum can suck only the gas which is exhaled into the other compartment. So this is the right scavenging system to be used, so that the exposure in the operatory or the nitrous oxide expelled into the operatory is limited. So active scavenging breathing system, airflow rate of 45 liters per minute at the nasal hood, which removes waste gas with low power suction to expiratory, it's to the outside area. Whereas you have passive scavenging by opening the doors and windows and using a floor level exhaust fan, and use the appropriate size nasal hood which has snug fit, so that nitrous oxide is not leaked into the operatory. APD recommendation to minimize exposure. So a machine which we use should have good scavenging system. The nasal hood what we use, it should be double nasal hood, but the ones what we are using right now, a single nasal hood which is disposable, so that we use it and give it to the patient. So when they come for the next appointment, let them get it. And the one other way of avoiding this exposure is, along with using the suction at 45 liters per minute, use the high volume suction which can be kept near to the nose, and it can always suck out the excess of nitrous oxide which is thrown into the operatory. And always administer 100% oxygen to the patient for at least 5 minutes during termination of treatment. Now, there are environmental concerns given about nitrous oxide, because nitrous oxide which is driven out, it can affect our greenhouse, and what is said is only 0.35 to 2% actually the result of the medical application of nitrous oxide, which is quite less. In US, there are many states where dental hygienists administer nitrous oxide. So it's high time we get into business. We straight away use nitrous oxide, which is least dangerous and least potent and safe in the hands of a dentist. Now, Namnini Sir Abbas, her study recently recommended appropriately sized and disposable nasal hood, rubber dam isolation, and extraoral vacuum device. Nitrous oxide inhalation sedation is considered as feasible pain management option during COVID-19 pandemic. So these are the studies which was done during this COVID times. Sevoflurane, which is a potent inhalation agent with MAC value 2% and a very narrow margin of safety, not safe as inhalation agent by the dentist. However, researchers into the use of sevoflurane is promising. So I conclude by saying nitrous oxide is our friend, and let's not consider as our enemy, and let's start using nitrous oxide, and let's all propagate this happy gas. Let's propagate this magical gas and do the best for the children, because present day parents have changed. In good old days, when a child is banged, is punished by the teacher, the student is reluctant to complain to the parent, because the parent is going to hit the child, saying that you have done a grave mistake, or else the teacher is not going to punish you. Nowadays, it's the parent who is all set to attack the teacher. So days are gone. So it's the right time we use the right techniques. It doesn't mean we move away from the fundamentals of behavior management. It's the communication is the key, and let's stick on to it. Plus, whatever armamentarium we have, let's enjoy them and let's use it to the fullest. So I thank everyone for patient listening, and I thank the authorities of APPD for giving me a platform. So thank you, everyone. And plus, I must thank Dr. Henna, who really took her time to create the slides for me. Thank you, Henna. So I hope, so these are my references. Thank you all. Thank you all for patient listening.
Thank you, Dr. Sunil, for the excellent lecture. We'll have the question answer session and discussion at the end. So over to Dr. Suresh for introducing the next speaker.
Sir,
Yeah.
Sir, since the time is 10 o'clock, so can we have it tomorrow, sir? Because another 1 more hour, it will be too late.
Okay.
So we can have question answer session for Sharat sir and Sunil sir right now. And we can have Ashwin sir tomorrow at 7.
You told Ashwin, Dr. Ashwin?
Yeah, we have just conveyed the message to Dr. Ashwin. I think his talk also might be another 1 hour, so it will be 11. So it will be too late.
Fine. Then we can have the discussion of
Yeah, right now we can, Sharat sir and Sunil sir's discussion we can have right now.
I think Dr. Sharath has got to. Sharath is there?
I'll call him.
2-3 questions are there.
Dr. Suprasad, can you please call Sharat sir?
Sure, sir. Sure.
Hello, Dr. Sharath.
Hello, sir.
Sharath, you got some 3 questions.
Okay.
One is from Sangeeta. She has asked, how will you plan your personal pediatric dental clinic? What are the factors you incorporate that help in guiding the child's behavior?
Okay. See, as I told you, these are all whatever comes to your mind, whatever would make the child comfortable. I think you should consider all that, right? Right from the point of entry, how you will want your reception, who's going to, how you want to see. This is like I told you yesterday about this counter conditioning also. So you have to look at your team attitude, your organization, and how you will plan. If it's a short notes or if it's an essay, you can say how much play area space you would like to have, what theme you would like to have, what kind of an aquarium, what kind of a fish, what kind of lightings. You must have a restroom definitely, because children will want to take a break, right? So you have to accommodate all these kinds of things. You might need place to sit and draw, right? So I think this is pretty much a setting up a pediatric dental practice. I think this is entirely a small chapter in most of our textbooks, right? Even in MS Muthu or this thing, we have a chapter on setting up pediatric dental practice. So you can always add all your imaginations with your team, what you want. Some people want a water theme. When we set up our practice in Meenakshi, I still remember in Meenakshi Mall Dental College, we had a jungle theme for the UG segment, and then we had a water theme for the postgraduate segment, because the postgraduate segment was AC, and that was the first time in Tamil Nadu we had a theme kind of thing. So I think pretty much it's just your imagination, but just it has to be friendly. That's the most important thing.
Okay. One more question on same personally. Should weaning behavior and timid behavior be considered as positive or negative behavior in Frankel's behavior rating scale?
Okay. I think, I don't know, don't catch me wrong here. I told you there are two important classifications. One is Frankel's classification. The other one is Wright's classification. So I'm not trying to tell you to associate both and try to fit in one classification into another classification. Try to see whether the child is coming under positive, negative, definitely positive, definitely negative on one side. That is on Frankel. Then see whether the child comes under timid or whining or tense cooperative or something. Don't try to see whether this fits in. See, a child who is timid can be negative also. A child who is timid can be positive also. So I'm only asking you to do both the classifications. Try to see whether the child is positive, negative. At the same time, if the child is whining, but he is allowing you to treatment, that means I would say he's positive. The child is timid, hiding behind the mother, but accepts treatment. That's exactly why I told you Frankel's behavior rating scale is something amazing. But most of the time we take it like a very easy classification. Who is reluctant to accept treatment? Who refuses to treatment? See, refuses and reluctant are two different words, right? So imaginarily accepts dental treatment, showing positive attitude. So very, very important words are written in by Wright in that Frankel's this thing. So you have to be very careful in saying a child who is timid can accept dental treatment. If he accepts dental treatment and he is shy and he does not want to talk, I will still rate him as positive. So I would assess, I would try to don't club up classifications. Try to see in which theory the child falls, each theory what it says, each classification what it has. That's why I said no classification is the best classification. All classifications you try to see that.
Okay. One more question. What is it? It is from Naseem P. Hamza. What is the difference between repression and regression?
Okay. Again, I don't know if it was. It's a little bit very tricky to explain this unless you understand what is. How do I say this? See, we spoke about ego defense mechanisms yesterday. So when you talk about ego defense mechanisms, one of the defense mechanisms or both of the things are defense mechanisms. But when you say repression, what do I say? You are trying to deny an instinct craving. See, I told you there are two kinds of urges, right? The urges are either by the sexual urges or it is an aggressive urge, right? So if you try to keep something pressed within, right? The id always tries to keep everything compressed within, right? We always try to say if you try to hide something deep down, and sometimes it bursts outside. Repression is trying to push everything into the subconscious state, right? When you talk about regression just means it's going back, right? So what Sigmund Freud always thought was you can always move from a higher kind of an evolution when thinking. You can always go back into a cocoon kind of a state. Maybe I will definitely give you some other example to remember between regression and repression. But only thing, if you really want to understand, you must understand ego defense mechanism by Sigmund Freud. The entire psychoanalysis. It might not be really okay. I'll give you like I'll just take a minute. There's one called denial. If you smoke, okay, and you say that this smoking is not injurious to me, right? It's an ego defense mechanism, right? Because you know that it's an external stimuli which is not good for your health, but you still smoke and saying this particular cigarette is not going to affect me. This is denial. But if the same thing happens inside your head, it is repression. Meaning, if you feel something and you try to repress it, you try to say that that should not create something, right? A cigarette is an external factor. There are some dirty things which you feel, right? And you don't want to do that. You keep it repressed inside, that is called repression. Your ego will not allow you to do something. I told you there's a good part and a bad part, and something pops up and says, don't do this. You're not supposed to do it. You keep it. You keep it inside, right? So it arises out of unconscious activities, right? So you have to be very careful in keeping it inside. That's what repression means. I don't know whether I answered that question well, but it's I don't think it's really useful in our pediatric dental practice. It's more into too much of psychology, selection.
Yeah. One more thing is biofeedback therapy useful in children? Can you elaborate on the effectiveness of aromatherapy and when to use impulsion?
Yeah. I think Dr. Shokma's articles on biofeedback, that was one of the first articles in India to have a cognitive biofeedback, because they had it in Narayana Medical College. I've seen that. They've done a dissertation on that. That article was published also. Biofeedback definitely helps. See, biofeedback, I think there was one article from Mumbai, Rupinder Bhatia's madam's PG had done on orange oil, right? I think there was one more study attempted on lavender oil, right? So these are small studies done by different postgraduate departments on maybe 30, 40 students. You divide them into two groups and then give them some aromatherapy and then try to say, has it given a calming, soothing effect? Yes, it works, right? If a child can relax and calm himself with breathing, with yoga, with meditation, with aromatherapy, with biofeedback, it works. In the study done in Narayana Dental College, there is something like a screen in which the child should actually make sure that he's relaxed. If he's relaxed, that means it will be in green. If he's getting tensed and he's becoming anxious, the balloon or something turns red. So the child has to try and make sure that he's calm and composed, that the color still remains green and not red. So it will obviously work. Anything which calms the child, soothes the child, definitely will work. It will work, sir. Aromatherapy and all this definitely works.
Okay, I think Anantharaj, any other questions? I don't get.
I don't think so. Anything like that. So I have a doubt actually. Hand-over-mouth exercise and aversive conditioning. Can it be used interchange, or somewhere it has been written that hand-over-mouth exercise bracket aversive conditioning?
Okay. Technically, the issue is we use hand-over-mouth exercise with voice control. Hand-over-mouth exercise is works when you use voice control. Voice control should immediately go hand in hand with your voice control, right? So anything which was collectively like that was termed as aversive conditioning. So there's no clarity like only hand-over-mouth exercise is aversive conditioning. With voice control, when you are actually literally calming down the child with your hand on the mouth, it's like a kind of physical restraint also. So there's a classical line by Chambers, 1977, that most of this aversive conditioning, they go together. Voice control won't be effective separately. Voice control always goes with that facial expression. This voice control is best followed with hand-over-mouth exercise. So you can't say hand-over-mouth is equal to aversive conditioning. Aversive conditioning includes these kinds of things which are basically an aversion for the child. That's how I would like to look at it. What happens in our Indian textbooks is when they try to equate, they put it within bracket trying to say this is almost equal to that. It's not like that. See, when we talk about flooding and implosion therapy, we always try to equate flooding and implosion therapy equal, but it's not the same, right? In implosion therapy, the child is not actually getting anything. He's made to think. He's made to think about something he's scared. If he does not like a spider, they make sure they talk about spiders, they show pictures of spiders, they make him think about spiders, but no spider is shown. But in flooding, the child has to look at a spider. The child has to stay in a room with a spider. That's how it works. So implosion therapy and flooding are two different things. One is subjective. He's made to think like that. The other one is like this. Exactly the same problem with aversive conditioning and hand-over-mouth exercise. I'm glad that you asked it this because most of the time, even I had the doubt, aversive conditioning, is it equal to this thing? Because the word, they have always used this word. They called it aversive conditioning, right? When we say Levitas familiarized it, the person called it a hand-over-mouth exercise. Other person gave the name aversive conditioning. But aversive conditioning is not equivalent to home. Home is a technique where you keep the hand over the mouth. But when it is used along with something, it is considered aversive conditioning.
Thank you, sir.
For regression and repression, I will put a good example in the group because I am not satisfied with that answer. I'll get back with a better answer.
Okay. I think, Varma sir, I think you must have seen another question for Sunil Muhammad. One question.
I didn't see any question. If you have seen it.
I'll read it.
Yeah.
Sunil, can nitrous oxide be used in claustrophobic patients, child?
Dr.
Sunil,
Sunil,
your mic is muted.
Muted.
Sunil, it is muted.
We still can't hear you.
Sunil, sir, your mic is muted.
Right? Okay.
Yes, sir.
Yeah.
Sorry.
Sunil, I think 2-3 questions are coming.
Yeah.
Can nitrous oxide be used in claustrophobic child?
Claustrophobic.
Claustrophobic.
Claustrophobic children, actually, it can be used by talking to them and soothing them and letting them allow to place on the nose. Actually, they are scared of closed spaces. But at the same time, it's through your behavior and actions you can actually achieve it. It's not a definite contraindication. You can do it. It's your trick in using it.
Okay. One more question from Chandrajit. What is the best sedation technique in child with andrograde amnesia?
Sorry, what is the
best sedation technique in child with andrograde amnesia?
I don't know. I'm so sorry.
Okay.
Anyone who has an answer for this?
Okay, that will. One more thing, can you explain about the pin index system? I don't know what it is. Pin index system.
Great, yeah. Pin index safety system is you have sort of pins jetting out from the yoke stand. That means there are 2 pins which is jetting out for nitrous oxide cylinder, and there are holes on the cylinder and pins on the yoke stand. So the way it is placed, the oxygen cylinder can go only to the oxygen yoke. the pin is placed with such a difference that the holes will not coincide. So for oxygen pin, only oxygen cylinder can be attached, not nitrous. You cannot interchange. It is because the pin, the size of the pin and the difference between the placement, only oxygen can enter into the portal of the oxygen and nitrous into nitrogen portal. So that way it's safe. You cannot interchange and connect. That is pin index safety system.
Okay.
I hope that clears it out. 2 holes on the cylinder, 2 male components on the yoke stand. So the 2 holes has to go into these 2 pins. So the oxygen can go only into the oxygen port because the holes it is differently. Yes. I hope that makes it clear.
Yeah. Okay. Anantharaj and Suprasid. Bhatna sir has to tell something.
Now, just a curious question. In this present day of COVID, wherein you have the attire, you are masking everybody and all that, how do you communicate and how do you manage this? Sharath,
Yes, sir.
do you need a special theory for behavior?
Nothing, sir. I generally, what I have been doing is I only wear one mask when the child walks in. And most of the time I wear all the aprons in front of him. So he sees me like me. And then I tell him, you have a raincoat, I wear a raincoat. Right? So I drape him and then I wear my apron. Then I say, I'm going to use a water shower. And then I don't want that water to fall on my face. Then I use my face shield. And I know that there are some postgraduates, some of the pediatric dentists were using some icons, like they were trying to have colored face shields and goggles kind of thing. So it's just a way of doing things. So I ask him whether if I have a vinyl gloves, which is blue in color, I ask him which one to wear, the white one or the blue one. So I just give them some choices. So I literally dress myself in front of him. So he knows it's the same doctor, but then only thing is I am just getting him ready for that. Nothing much, sir. I never had a problem in wearing anything, sir. Like I didn't have any trouble in wearing a face shield or wearing a PPE kit or anything.
I think we should slowly think of having PPE kits in various pediatric
colors. Yes, sir. It's already there, sir. It's already there. Because when we don't want to use the white coats, we use the colored ones. So it's already there, sir. Like there are lots of PPE kits which are coming up with different themes and stuff like that.
Yeah.
Even the nurses, I think there was one video with the nurses abroad, they were wearing that and trying to do that. Maybe it might work out expensive in a private practice, but I'm sure it will be good, sir.
Yeah.
This was the question I had asked Sharath sir when he took this class in state IDA program.
Okay. I have a very bad memory. I don't remember whether I answered that at that time. Maybe I said the same answer.
But I think my experience through this year says that a child who is going to cooperate will cooperate irrespective of our attire.
No, all children will cooperate. We go with the right. All children are cooperative.
Yeah,
only thing is
cooperative and more, a child who is not decided to cooperate that day, I think our attire is not going to make any difference in his decision.
I know it's getting late, sir, but I just wanted to add one more thing. Like when I was in Chennai, there were only 3 of us or 4 of us were doing general anesthesia cases. But after I shifted to Erode, which is almost 10 years from now, the last 10 years, I probably did 10 general anesthesia. I think every child who cries at 2 years, 3 years, I'm still able to manage. I don't know whether I'm aging gracefully or I'm against the concept of sedation and this thing now. Because I did nitrous oxide in my department. I did general anesthesia, right and left general anesthesia, almost 4 patients in a month at some time in Chennai in 2005 and 2008. And then now general anesthesia. I think I really don't want to put a tube inside the child's nose. And I still think I can manage the child, sir. I think it's only because of your concepts get in And when everybody asked me whether it's going to be a PPE kit, only thing I wanted to make sure that the child was comfortable seeing me wearing that, right? So I just had to create more stories on that.
Okay, to wrap up, what I just want to tell the postgraduates that, when you pass out and go as a consultant pediatric dentist, basically a general dentist will give you cases which they cannot do, which they cannot manage. And as a pediatric dentist, one cannot say, I cannot manage. You have to somehow manage. That is when these theories and what you have learned, the pharmacological and the non-pharmacological comes in. And somehow you will have to manage. So that's the application part. And as a pediatric dentist, you can never say, I cannot manage. That is why you are there. That's the most important thing, which I think everyone has to learn. And thank you for the very good session, the two speakers. It was very interesting, both of you, Sharat and Sunil. And
Thank you.
Thank you. Anything else, Dr. Suresh?
Nothing. Actually, I think Dr. Mamachan, Arun Mamachan has sent a thing. I would suggest in regression, the child has a ego defense mechanism, starts a habit which he uses while in stress, like thumb sucking or nail biting. In repression, the child tries to convince his mind process by thinking of some past soothing experience, basically a kind of mind game. That's what he has written. Maybe helpful for the PGs. That's why I read it. Okay.
Thank you.
Thank you so.
Dr. Anandraj, are you
Yeah.
there?
Thank you, sir. Thank you, sir, Balagopal sir, and Suresh sir for moderating the session. And thank you so much for Sharat sir for sharing your wisdom and knowledge. And that too, after traveling at 250 kilometers. And
Actually, this was one of the best extempore things I think I did today. Usually I don't prepare for a psychology and this thing, so it comes from my heart. But driving 250 kilometers in 3.5 hours or 3 hours and then coming and sitting just right in front of the system and opening, I think it was good for me. It was a real challenge, but I don't know. I don't know whether I made sense. That's the only thing I'm hoping that I made some sense.
yeah.
Thank you, Anandraj, for that delayed start was very useful for me to reach home. Thank you.
Thank you, Sunil. Thank you, Sunil sir also.
Anandraj, did I take too much of time and spoil this show?
No. It was informative actually. No, not at all. Because it was getting late
like,
actually.
I was worried, like I took more time and I spoiled the whole thing.
No. Actually, it was a little late actually. So it's okay. Because tomorrow, I think the Ashwin sir also required almost 1 hour time. So again, 1 more hour, then our discussion will be little late. So that's why I have changed. Okay.
Fine.
Okay. Anyway, we all have a lockdown, so there is no issues in having classes anytime. So not at all a problem. So tomorrow, same time, 7 o'clock, we'll have 1 hour session and we can finish.
Oh, sure. Good night.
Thank you.
Thank you.
Good night, sir. Thank you, sir.
Good night.
Right.